Amy Fidelis shall now lead us in the opening prayer.
Shall we bow our head as we pray? Let's pray. Our most gracious Father in heaven, we come before you once again in this morning to thank you for your protection, to thank you for your guidance, mercy, and love that you have been bestowed upon us. May your name be glorified. Thank you for allowing us today to meet and share our knowledge and time with one another virtually. May you send forth your divine wishes to our speakers as they impact effectively God-given gifts and wisdom to all of us. May they be blessed as they continue to share their expertise to the people who need them. May you also bless the participants as well, so that they will be able to obtain vital information from this webinar. May you send forth your Holy Spirit, so that after this webinar, we may also be able to implement and willing to share what we learn in spirit of your love and generosity. May you accept our humble prayer this morning. In Jesus' name we pray and trust. Amen.
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 At this juncture, we shall now be welcoming Dr. Susie Hael to formally welcome our guest this morning. Dr. Hael?
Good morning, Mamars. Thank you. Am I clear?
Yes, ma'am. Loud and clear.
Okay. Good morning, everyone.
Good morning.
Thank you. I would like to start by saying it's the most wonderful time of the semester and of the year, of course. Why? It's because the semester is about to end. And for students, you are one semester closer to your graduation. And for faculty, we are 1 year closer to our retirement. And for 1 year, we should be happy because we were able to inspire and touch the lives of our students. So indeed, we have many beautiful and wonderful things to celebrate this year. And with that inspiring thought, may we continue to inspire and influence others. To the organizers of this webinar, thank you for this opportunity to join you today. My appreciation to the students of the Growing Family class, through the supervision of Dr. Joy Orbe, your professor, to conduct this seminar in spite of being a holiday today. And of course, we are happy because you have invited resource speakers who are willing to share their evolving knowledge, expertise, and experiences. We have here Doctors Silvestre, Pam Stout, and our very own Marge Sibayan. Welcome and thank you so much for accepting the invitation of our students. And we are happy, we are excited actually to gain new insights from your sharing today. So on behalf of the AUP College of Nursing, Graduate Nursing Department, it is with profound joy that I welcome all of you, our students, professors, and our guests. Thank you and welcome everyone.
Thank you, Dina Hel, for always being supportive of the programs that we have, Dr. Susie Hael. At this point, I am very much honored to be introducing our first speaker. Dr. Maria Asuncion Silvestre is a pediatrician who specialized in neonatal perinatal medicine at the Children's Hospital of Michigan of the Detroit Medical Center. Upon return to the Philippines, she joined her alma mater, the University of the Philippines College of Medicine, and the Philippine General Hospital. In 2010, she founded a nonprofit Kalusugan na Mag-ina Incorporated, or KMI, which translated means Health of Mother and Child, dedicated to the health of the mother-child dyad. With WHO Philippines, she collaborated on the implementation of the essential intrapartum and newborn care, or Unang Yakap, or the First Embrace, in 2008. A time-bound sequence of evidence-based life-saving interventions in the labor, delivery, and immediate postnatal period. As the First Embrace, the program is now being implemented in at least 9 countries in the Western Pacific region of the WHO. She is currently chair of the Independent Review Group of Early Essential Newborn Care, EENCIRG, of the WHO Western Pacific Regional Office, WHOWPRO. She was and is a member of the various WHO guideline development groups, including that of the management of COVID-19 illness from 2020 up to the present, and various infant feeding guidelines. Dr. Silvestre is a multi-awarded physician. Most recent of her awards are Most Outstanding Pediatrician of the Philippine Medical Association of 2021 and Most Outstanding Medical Services Award from the UP Medical Alumni Association of 2022. Dr. Silvestre sits on the Global Medical Advisory Group of Smile Train and is a member of the Newborn Care Group with focus on nutrition. Without further ado, we shall now give the time to Dr. Mian Silvestre. Dr. Silvestre?
Maraming salamat, my co-speaker Marge. And I'd like to express my gratitude to the Center for Graduate Studies, tama ba? And of course, thank you, Dr. Dean Susie, for this invitation. And hello, of course, to Pam Stout, our co-speaker, who is currently, I understand, in Texas. Thank you for this opportunity to reach out to the pre-service arm of nursing education. I consider it a very important opportunity to reach out to both undergraduate and graduate students. So if you will please allow me to share my screen.
Doc, I think you are, yes. We can see
Oh,
your screen. Yes,
wonderful.
yes.
Okay. I'll try to speak as fast as possible. I'd like to, of course, first start off with a disclaimer, which we always do. Salamat, Marge, for introducing our nonprofit, Kalusugan na Mag-ina, a beautiful term in our languages, in our dialect. One word denoting the mother and child dyad, no? And our nonprofit, founded in 2010, set out on this mission to promote and protect the health of the mother-child dyad through research, policy development, training, and program implementation, at that time towards the vision of eliminating preventable causes of deaths of mothers and their children. I declare no financial relationships with the manufacturers, distributors of tobacco products, and any breast milk substitute, so to speak, nor any product covered by the executive order, our national law, nicknamed the Philippine Milk Code. Hopefully, by the end of this session, our learners, both undergraduate and graduate students, will be able to link what we're going to talk about to the problems of both maternal and child mortality, but focusing a little more, leaning towards neonatal mortality, know the preventive interventions to address the above, and to be able to discuss in the immediate newborn care period practices that can save both mothers and babies' lives. So this is my outline, and I will not read it off anymore. Let's start with this, a so-called integrated approach, a life stage approach that nursing students, master's students in MNH, MNCH especially, need to really absorb, is that our work doesn't start just with labor, delivery, and the immediate newborn period. It starts with pre-pregnancy, preparing a couple, the mother for her pregnancy and the profound changes that she's going to undergo at each even premarital visit or prenatal counseling or antenatal counseling visit, to prepare her for what to expect during labor, delivery, and the postnatal period, to express, to be able to express in her birth plan her expressed desires and entitlements to a positive birth experience. And of course, afterwards, when she comes into labor or pre-elective cesarean section or even postnatally. Pregnancy and childbirth is a critical period for the survival of both mothers and infants. And as you see here, the spikes in both newborn and maternal mortality are in those first 1 to 2 days after birth. And if you consider that this is a critical period for both mother and baby, we emphasize really that the mother and the baby should be cared for as a dyad, as a unit, as an inseparable sociological and biological unit, no? When you look at pediatric or under 5 deaths, at least reported in the Global Observatory between 2000 and 2015, for every 100 children who die before their 5th birthday, you will see here that almost half of them die in the first month after birth. So what do mothers die of? It's in the Philippines, the predominant causes of death are still postpartum hemorrhage, hypertensive disorders of pregnancy, and puerperal or intrapartum and postpartum sepsis, disseminated infection. And of course, we have other causes of death like unsafe abortions, rarer causes like embolism, and other indirect causes arising from underlying medical complications that the mothers might have. Faced with this, in 2012 and 2015 and 2017, our Philippine Obstetric and Gynecologic Society actually conducted what's called an evidence-based clinical practice guideline development process called GRADE. We had to use evidence to change behavior of our obstetricians and also our midwives in the primary care level. So in these 2 documents, plus the recently published 2018 document, of the WHO called the Intrapartum Care for a Positive Childbirth Experience. Outlined here are essential intrapartum meaning labor and delivery period, no? Emphasizing that care of all healthy pregnant women, those that have no risk factors, and their babies during childbirth, labor and childbirth in any healthcare setting are covered by these recommendations, and that essential care that should be provided throughout labor and childbirth and interventions specific to the first, second, third, and even the fourth stages of so-called labor should be practiced, no? A very short summary of some of these recommendations are that all women are entitled to a respectful and a dignified birth. They should be entitled to a companion of choice to boost their moral support and emotional support during this very uncharted territory called childbirth. They're entitled to clear communication by maternity staff. They're entitled to pain relief strategies, but they're not entitled to an over-medicalized birth. And they're entitled, briefly, to mobility in labor and birth position of choice. I don't have a lot of time to discuss all of them, but imagine you, for example, for the males in the audience, and you have a very severe episode of constipation. You don't lie in your bed flat. You assume either a semi-upright or a knee chest position so that you can push out that hard object, okay? So encouraging mobility, women know where the presenting part is. They can feel as the baby goes through their birth canal, no? And the supine position is probably the worst position to be in during labor and delivery. And this upright position is being recommended both by WHO and the Department of Health Philippines. These are some positions of choice that I cannot go over. The husband, being the companion of choice, is probably the best source of both emotional, moral support, and also can even help with allowing the mother her position of choice. Intrapartum care practices that are recommended, you will learn as you go through your nursing studies that the uterotonic, no, to make the uterus uterine musculature clamp and spasm, is the uterotonic of choice is oxytocin, no longer methergine, that you might be still seeing in some of the remote health centers that haven't been trained yet. But oxytocin, after exclusion of a second baby, for women at low risk, do not put them NPO, do not allow them, do not make them abstain from food. They can be allowed oral fluid and food intake. No routine IV fluids is what we are recommending now, and encouragement of the adoption of mobility and an upright position during labor at low risk. We are not recommending anymore practices that you might still be witnessing in some of the hospitals and health centers. Some of these practices are listed here: vaginal cleansing with chlorhexidine, a package of care for prevention of delay to delay labor, use of rupturing the bag of water, the so-called amniotomy procedure, or with oxytocin augmentation. Oxytocin is just in the after exclusion of a second baby, before delivery of the placenta. Non-use of oxytocin, non-use of antispasmodic agents to delay labor, and the use of routine intravenous fluids. Okay, let's go to the baby. If a newborn were to die, what does the data show? The data shows that if a newborn were to die, that newborn is most likely to die in the first 24, if not 40 hours after having been born, okay? In fact, globally, 3 out of the 4 newborn deaths occur in that first week of life, although afterwards, especially for preterm babies and other babies with high-risk conditions, you still have some neonatal deaths that are considered late neonatal deaths. So what did we find is that we did not have any discrete programs for the newborns in the immediate newborn care period, way back in 2008 and 2007 even. And that the assumption that the pregnancy was healthy would so-called produce a good outcome for the baby. That assumption was flawed, and that we did need a package of discrete interventions for the baby to save these babies from dying, especially in the first 2 weeks of life. What are babies dying from? Reflecting global data, we still have in the Philippines that prematurity, intrapartum related events, or what you probably know better as asphyxia, and number 3, disseminated infections of these babies, the so-called sepsis. We're still the top 3, but the top 3 and 4 slots for the predominant causes of neonatal death were shifting between congenital anomalies and neonatal sepsis or infections. Going to sepsis, what we used was some very important information from a poor country like ours, Nepal, where in Nepal, almost all babies are exclusively breastfed. So they took a cohort, a so-called cohort of almost 23,000 breastfed babies, and they correlated the risk for infection-related death, okay, sepsis-related death, to not just whether or not they're breastfed, because most of them were breastfed, but when breastfeeding was initiated. And what did they find? They found as the first successful breastfeed is delayed, okay, using as a baseline breastfeeding within the first hour, they find that delaying the first breastfeed even outside of the first hour, but still within the first 24 hours or the first day of life, you already double the risk of the newborn dying from infection in a low income country like Nepal. For the Philippines, a low to middle income country. Delaying, for example, up to 2 or 3 days, for example, a post-cesarean mother who only is reunited with her baby when her anesthesiologist or her obstetrician expresses, okay, she's been able to rest now, or okay, we can discharge her. You can discharge the baby straight with the mother. Delaying the first breastfeed until 2 to 3 days, okay, already quadruples the risk of these babies dying from infection-related death. And with these types of information, plus our formative research, we went into 51 large government hospitals here in the Philippines with the endorsement of our Department of Health, and we did direct delivery observations of the immediate newborn care practices that our skilled birth attendants implement or perform in the immediate newborn care period, the seconds to the minutes to the hours after birth. We found that there were many routine practices that were actually preempting the baby's thermoregulation and preempting the first breastfeed. So what are these practices? Routine suctioning of the airway, routine immediate cutting of the cord, routine IV fluids in the mother that was preempting her from being able to carry her baby. So these were some of the newborn care practices that we knew we had to eliminate, okay? Bathing, early bathing, even without the babies having achieved thermoregulation. We took this data from formative research and convinced hospitals to change practices. We know that babies requiring advanced resuscitation, what do we mean by that? That's intubation, that's cardiac compressions, that's medications. We know that only less than 1% of them will require intubation, provided all of the babies, whether with congenital anomalies or not, whether preterm or not, undergo a rapid sequence. And what is that rapid sequence? It is immediate and thorough drying, during which a quick check of breathing is performed, followed by early skin-to-skin contact with the mother. Ma'am Pam is about to lecture also on skin-to-skin contact. And the fourth step, which we will see later, non-separation of the baby from the mother so that that first life-saving breastfeeding can be completed. So we set out to re-choreograph basically what skilled birth attendants do in the immediate seconds, minutes, and hours after birth, so that the routine suctioning, the immediate cord clamping, the immediate separation of a baby in an observation area, immediate wrapping and swaddling of the baby, putting mittens on the baby, all these practices are re-choreographed, are changed so that the baby can derive the benefits and all the wonders of what we call here in the Philippines, unang yakap, which is directly translated to the first embrace. So being that there was no discrete program in the intrapartum period, we set out to change those behaviors and convincing even solitary birth attendants that this rapid sequence of actions for the baby immediately after birth are intertwined. Even if you're performing them solo, you're a solitary birth attendant, that there are specific times, even if you zoom out in the grand scheme of things, you can perform the care of both the mother and the baby in the second, third, and even in the fourth stage of labor, even if you have only 2 pairs of hands. Okay, so I cannot go into this, but this slide emphasizes the time-bound sequence, of immediate newborn care practices that can be intertwined with the steps to save the mother's life, like giving of the IM uterotonic of choice. We are no longer emphasizing a lot of uterine massage or controlled cord traction, but if you are trained, by all means, yes. Okay. We set out to use the evidence that we derived from our grade CPG guideline, combine essential newborn care protocols and the CPG on essential intrapartum care, but we did not stop there. We designed a job aid, the so-called Blue Pocket Guide for Newborn Care until the first week of life, that was a little bit unique in that it was organized by time bands rather than by problem. And instead of emphasizing newborn resuscitation, which is buried here in the 5th section called additional care, we emphasized essential care for all babies, whether preterm, term, congenital anomalies or not. This eventually allowed us to re-choreograph the actions, as I said, in the immediate newborn care period. Eventually, this became the regional pocket guide as the Western Pacific region of WHO translated our unang yakap into the first embrace and our EINC protocol into the early essential newborn care program, which is essentially a quality improvement program here in the Western Pacific. Initially, it started with 8 countries, including the big WEPRO nations like China, and of course, the very high-risk populations in Vietnam, Cambodia, the Philippines, Laos, the Asia-Pacific countries like Papua New Guinea, the Solomon Islands, and now the 9th nation, Vanuatu. So what are these immediate newborn practices that save lives? In the immediate antenatal period for preterm babies, to save the baby's lives, we recommend giving of dexamethasone. So you will hear about this as you go upward in your nursing career. Dexamethasone is administered to the mother. It should not be stored in the pharmacy. It should be stored in the or emergency cart in your either emergency room or OB admitting section. And we have other guidelines for other specifics, okay? These are just a picture of a baby on the left who did not receive steroids, whose mother did not receive steroids because she was immediately C-sectioned because of eclampsia, okay? Did not receive steroids. And if you'll notice, at 760 grams, this baby required mechanical ventilation via the tube in his airway. He required cannulation. You can see the line there in his umbilicus. And of course, an IV access line, but a smaller baby at 460 grams who was able to undergo the full course of antenatal steroids is just on room air without intubation, just has an orogastric tube, but eventually the baby was put early to the breast and advanced on feedings, okay? We emphasize that every newborn has immediate needs, and these are regardless of race, regardless of country, regardless of other factors, that each baby should be able to breathe normally, should be kept warm, should be protected, and a little bit later to be fed, okay? As such, especially as nursing staff, whether in the operating room or in the delivery room, you should have a non-mercury thermometer. When we set out to change these practices, you would not believe the number of delivery rooms that did not have thermometers, or that had thermometers, but the temperature was set at 18 so that our obstetric surgeons were comfortable in their scrubs, etc. You should check for air drafts, and you should turn off those fans and air conditioners before the delivery, especially the cesarean deliveries, okay? If you could please type in your questions in the chat box. May I ask you, after a baby is born, what should be the first action performed? Is it A, clamp and cut the cord? Is it B, dry the baby? Is it C, suction the baby's nose? Or is it D, which is what we saw, do footprinting, because there were teams of babies there, okay? So I see a lot of answers coming in now. Thank you very much. And I don't think we need 30 seconds for this, because the answer is B. You will not believe that up to about 11 years ago, the answer was still suction the baby's nose. And for obstetricians, it was clamp and cut the cord. So now, thanks to our nursing pre-service and in-service education, I see here a unanimous choice of answer number B, which is dry the baby, okay? We did say that all babies require that rapid sequence of drying, including a quick check of breathing, and then once you remove the wet cloth, you establish early skin-to-skin contact. Tsaka pa lang, only then do you clamp and cut the cord so that you can allow non-separation in uninterrupted skin-to-skin contact and breastfeeding initiation. Those simple, essential newborn care recommendations are strong recommendations for all births across all health system settings, whether you're in an exclusive hospital, an exclusive private hospital, or in a island health center. Some of you might be deployed to our mountains or our islands. In all health centers, regardless of risk factor, regardless of the baby's condition or gestational age, they should be dried immediately. Okay, it should be immediate. What do you mean by immediate? Drying should be initiated within the first 5 seconds. Thus, you have to have warm, preferably, and dry linen available for a full 30 seconds, okay? Unless the infant is both floppy, limp, and apneic, then you can slightly reduce maybe the time by 5 seconds and proceed to resuscitation if it's required. But what is the importance of immediate drying? Not only does it help the baby thermoregulate because it removes moisture, but the tactile stimulation of the baby's back, rubbing the back. If the baby has not already cried, the tactile stimulation of the back rubbing stimulates breathing. So, and prevents, because of the better thermoregulation, prevents the complications of hypothermia, which are infection, clotting defects, buildup of acids in the blood, a delayed transition from the fetal to the infant circulation. The pediatricians here might understand what this is. A hyaline membrane disease, former name, now it's called respiratory distress syndrome, and in preterms especially, hypothermia can lead to brain hemorrhage. So this is the procedure. We always emphasize that if our babies are dried early and immediately, more than 95% will not require resuscitation and therefore separation from their mothers. Follow an organized sequence. We start off with the eye care, medial to lateral, then the mouth and nose, up to the back of the scalp, and then down to the back. By the time you're at the back, which is about maybe 15 seconds, most of the babies who have not cried will already cry and initiate breathing. Okay? Wipe gently, do not wipe off the vernix, which we know to be a very protective occlusive barrier, and that will eventually melt off. Do not bathe, remove the wet cloth, and now initiate early skin-to-skin contact. Step number 2. If the baby is not breathing, if you will see this picture, what can we see in this picture, do you think? Do you think the baby is pink? I won't look into the chat box, but you can do so. The baby is pink. Do you think the baby has tone? Yes, because the baby's arms are flexed. Do you think the baby has a grimace? Yes, it looks like if this had audio, the baby might be crying. Do you think the baby is dry? Not at all. And therefore, what's wrong in this picture is that suction device is out of place. Oops, okay, I'm so sorry. Okay, is that suction device should not be there, okay? And instead, the baby should be dried. You do not slap, shake, or rub the baby, or what I see in Facebook with some untrained birth attendants bending the baby over, correct, or rubbing them too vigorously. Do not ventilate or do not do ambu bagging unless the baby is floppy, limp, or not breathing, and do not suction routinely unless, in fact, the mouth and nose are truly blocked. Question: during drying and stimulation of the baby, your rapid assessment shows that the baby is crying. What is your next action? Is it A, now do we suction? B, clamp the cord? C, do skin-to-skin contact? Or D, I'll give you 5 seconds maybe just to type into the chat box, which I cannot see anymore, but your answer should be skin-to-skin contact. Dr. Marge, can you just document? Yes, thank you. I see now that most of you are saying C, skin-to-skin contact, and you're absolutely right. I will not go into the details anymore here. One of our participants devised a mnemonic to say that in the immediate newborn care period alone, these are some of the wonders of skin-to-skin contact. If you ask me why, how this works, we think it's because of stimulation of good hormones, okay, and avoidance of cortisol or stress surges in the baby. But I'm sure that Dr. Pam will be discussing this a little later on. So just imagine the wonderful benefits of skin-to-skin contact. That before all the attention was pretty much underrated, by our medical practitioners, especially, mea culpa, people like myself, pediatricians and neonatologists, okay? So position the baby prone in our first embrace protocol. The baby is positioned prone first. The picture doesn't show the woman in the semi-upright position, but we are partial to semi-upright so that the mother can see better her baby. Cover the newborn with her dry linen or back and a bonnet for her head. And of course, do a temperature check again of the room You can only raise the temperature of the room if the baby's temperature is between 36.5 to 37.5 degrees centigrade. Next, when should the cord be clamped after birth? Is it A, when the cord pulsations stop? Is it B, between 1 and 3 minutes? Is it C, not less than 1 minute, even in vigorous preterms who are breathing well? Or is it D, any of the above, A, B, or C? You might need a little longer. I see some picture. I think these are still the answers from the previous question. So this is the cord clamping question. I'm putting a place setter. Okay, some are saying A, some are saying B. Okay.
Mix na po yung answers, Doc.
It's a
Merong A,
toss.
merong B.
Okay, I'm seeing a toss-up between A and B. One person answered D.
Yes po.
One person answered C now. Okay, thank you very much. Okay, the answer actually now is D. It's D, okay? Because A is correct. When the cord pulsations that are transfusing placental blood from the placenta to the baby, okay, by chemosensory mechanisms, okay, only when the pulsations stop, okay, the arterioles of the umbilical cord stop pulsating, that signals the fact that the baby's oxygen level is good and that his carbon dioxide level or her carbon dioxide level has already gone down, okay? So we have graduate and undergraduate students here, so please allow me this license to explain some technical things, correct? And the pulsations usually stop, okay, at a minimum of 1 or 3. There are some that stop at 5, sometimes even more than 5 minutes, okay? But from a public health perspective, because even a 1-minute delay causes some impatient health workers to clamp immediately, in the recommendations, we found in our randomized controlled trial that 1 to 3 minutes is just as effective to allow better oxygenation, pinker babies, warmer babies, babies with stem cells already transfused, higher blood sugars, and all the other underrated benefits of that placental transfusion of blood, okay? In preterms, is it necessary to clamp them immediately and resuscitate them? It might be, but for the majority of the preterm newborns who are born, they will actually benefit, okay, from the delayed clamping of the cord, okay, because we have shown that anemia, the need for blood transfusions in especially the extremely preterm babies has gone down, okay? And later, anemia in infancy, even 2 to 4 months in the Philippines has also gone down, and people can stop blaming breast milk misleadingly, okay? So the answer is A, B, and C are appropriate answers, okay? I did mention that in preterm babies, properly timed cord clamping, the evidence shows that it reduces brain hemorrhage, it reduces anemia in term and preterm babies, and there is no significant risk to the mothers from having clamped the cord at a later period rather than immediately. So we are not risking the safety, the health of the mothers, okay? So there's no connection between postpartum hemorrhage and properly timed cord clamping. Here is where, in the Philippines, we might differ from other scenarios or contexts because many of our births in the Philippines might occur in the hands of a solitary birth attendant. So we teach them that if you are alone when you deliver, put on 2 pairs of gloves, after, of course, thorough hand washing, but remove the first set of gloves if you have to palpate the cord for pulsations, or of course, to cut it a little later on. So that first soiled set of gloves is removed first before handling the cord. And we have found that that procedure alone has prevented many outbreaks of omphalitis, okay, even in post-disaster situations here in the Philippines. We used to teach that you cut midway, but now we teach that the cord is clamped with a sterile plastic clamp or tie at 2 centimeters from the umbilical base. It is stripped of blood and clamped again at 5 centimeters. And now don't cut midway between the two clamps, but cut close to the umbilical clamp, the plastic umbilical clamp, and do not handle that cord again. Do not apply betadine, alcohol, chlorhexidine, and because what we adhere to is the so-called dry cord care. Okay, so the arrows indicate where to clamp and eventually cut. At this point in time, 2022, we do not recommend yet milking routinely of the cord towards the baby, not yet. But do observe for the oozing of blood and place a second tie between the skin and the clamp. Do not use a umbilical binder, or in the Philippines, it's called a big kiss. There are so many superstitions about the umbilical binder covering the umbilicals. So the current recommended practice is dry cord care, and the cord is left exposed to air. The skin-to-skin contact confers the benefits of the maternal skin flora, which is good skin flora, and the skin flora, the bacteria on the mother's skin, will contribute to accelerated dry gangrene. And as soon as the cord becomes gangrenous and dries off, it will fall off earlier. So current recommended care here in the Philippines is, of course, antenatal tetanus toxoid injections to prevent neonatal tetanus, no application, no spitting, no application of ash, no putting any substances, even dyes on the cord is recommended. Okay, next question. Bathing the baby in the first 6 hours is protective. Is it true or false? I hope that with the previous points raised, okay, I see answers coming up, and the answer is, of course, false. No, it takes about 4 to 6 hours for babies. The smaller the baby is, the longer the period of thermoregulation. But what we are recommending now in the countries of the WHO, Western Pacific region at the very least, is delay bathing until after the 24th hour. In some hospitals in the Philippines, they do not bathe anymore after the vernix, which is a protective barrier to E. coli and group B strep, 2 organisms that can be found in the maternal birth canal. After the initial hours, vernix will automatically melt off, and it doesn't. Of course, there are exceptions, babies that are thickly meconium stained or are foul smelling because of chorioamnionitis, infection of the mother's membranes, okay? Then these are the exceptions. But if you do need to bathe because of these conditions, then please avoid bathing in the first 6 hours at the very least, okay? We do not want early bathing to hinder the crawling reflex. In Tagalog, nadidiskaril sila. They become thrown off. Nawiwindang sila, no? They're disorganized because their programmed reflexes for crawling, for feeding, are all put off, okay? And of course, like we said, skin-to-skin contact is interrupted by the bathing, and the risk of hypothermia increases, okay? Fourth of the 4 core steps, non-separation of the newborn. Question: what is the approximate capacity of a newborn stomach? Is it here we have Filipino fruits and citrus fruits. A, is it chico? The size of a chico. Is it B, Tagalog na kamatis? Is it C, a large calamansi or our Philippine lime? Or is it D, bubot na calamansi? Okay, so I hope your questions are coming in. I can't see them yet, Marge. So maybe 5 seconds. 5, 4, 3, 2, 1. I see a variety. Some say B, some say D, some say
B, some say
A.
D.
Okay, great. Thank you very much. Okay. The correct answer is actually somewhere between C and D. Okay, why is this? No, D for preterm babies, maybe about 6 ml per kilo, and for term babies, somewhere around C, and post-term babies. Okay, so this is very important to tell to the mother, because most of them will be of the misperception that they don't have enough milk. Okay, that's the most common misperception. We do know that colostrum is produced starting maybe the 20th week of gestation, and that by the time a baby is born, milk is already there, but it just needs to let down. It will not drip or spurt or jet out because colostrum is thick, it's viscid, no? It's highly colored. Don't throw away colostrum. The baby is programmed to feed small and frequent, maybe in between his sleep periods, but that's what we're going after, is that these mothers are not pressured by the nursing staff, let's say, of the so-called nursery or NICU, to produce, okay, Mrs., give me, mommy, could you give me 6 ounces of milk? No, don't pressure the mother to produce that much, because the baby doesn't need it. And these are photographs from one of our mother support groups, care of Attorney Jenny and Stanley Ong, our photographer, to illustrate how much the capacity of small line is of a siniguelas, of a 1-week baby, and that is a small tomato, and of course at 1 month, maybe the size of a small chicken egg. Okay, so drive away the misconception that mothers do not have milk. Okay, there are mothers that might have quite relatively rare conditions, but this cannot be a message for all of the mothers that they probably don't have enough milk. Okay, question: how long is a newborn typically? And when we emphasize typically, we mean on the average. Okay, ready to breastfeed. Is it A, immediately after birth? Is it B, between 5 and 9 minutes? Is it C, between 10 and 19 minutes? Or is it D, typically on the average between 20 and 60 minutes? So by typically, I mean the majority of healthy babies. Okay, so let me just put a place setter, typical,
So the
ready
answers,
to,
Doc, that we're seeing would be a majority is C.
okay,
C
okay.
majority. Yes.
Okay, all right. So actually, this is coming from our formative research. It's somewhere between C and D, but to allow for even cesarean mothers, okay, we usually say D. Okay, the ones like our barracudas, so-called barracudas, yeah, at about 15, oh, they're all at it. Okay, but the ones whose mothers may have been sedated a little, etc., etc. That's why in our recommendations, we say, don't touch the baby. Allow these babies their transition period, which could be anywhere from 0 to 15 to 20 minutes, and make it feeding cue based initiation. So don't force the baby onto the mother's breast. No, in Tagalog, pardon our non-Tagalog speaking, okay? In Tagalog, wag isalpak, wag isubsob. No, don't recommend to the skilled birth attendants that they force the baby onto the breast, especially during a transition period where the baby's heart and lung systems undergo one of the most profound hemodynamic changes, no, that a human will undergo. Those hemodynamic changes occur in the first maybe 15 to 20 minutes. No, so feeding cue-based initiation, and what is corollary to that, okay? During the first breastfeed, okay, make that skin-to-skin contact uninterrupted, okay? Defer, postpone other routine care procedures, like, for example, eye care, application of an antibiotic for prophylaxis against ophthalmia neonatorum. Don't weigh the baby just yet. You don't need an immediate birth weight in the first hour, actually, or even the first day after birth. Sometimes they're so waterlogged from having routinely IV fluid bolus, the mothers, no? So, and later, because the weight goes down, deriving from uncalibrated weighing scales, Don't weigh the baby until, at the very least, the first breastfeed has been completed. Remove your weighing scales from the delivery area and the OR. And we're trying to get that message out to our obstetricians. Don't ask us about birth weight in the first crucial 1 to 2 hours of life. We can do that a little later on, okay? The first newborn examination is during drying. Okay, you can do a gross inspection or visualization of the baby and his breathing, but the first thorough examination happens after the first breastfeed too, okay? So with injections, here in the Philippines, we inject vitamin K and the first doses or the birth doses of hepatitis B and BCG. And all these injections should be performed after the first thorough examination. You don't want to inject a baby without doing a thorough physical exam and communicating the baby's condition to the mother, because whatever you do and some adverse effect arises, you will be blamed, okay? Even Mongolian spots, they might blame you because you did not communicate the baby's thorough physical examination findings and his overall condition to a mother, okay? So here we have the routine care done while the baby is in the company of the mother, okay, or within sight and hearing of her baby, okay? So inform the mother, and especially as our audience is nurses, record all actions taken. And like we already said, postpone bathing, never leave the mother of the baby or the baby unattended, and monitor the mother and the baby every 15 minutes in the first 1 to 2 hours. It can be difficult, but in a busy postnatal ward, but even if you can just eyeball the baby and see their pink feet and that they're not grunting or and they look warm even without drop lights, then you will have done your job well, okay? Leave the newborn between the mother in continuous skin-to-skin contact. The baby, like we said, may want to rest, quote unquote, for maybe 15, 20, or 30 minutes, and even up to 120 minutes for cesarean babies before they show signs of readiness. So the evidence is solid. The time-bound rapid sequence of immediate and thorough drying followed almost immediately or simultaneously with early skin-to-skin contact that preempts properly time, that preempts cord clamping. So it pushes cord clamping downwards as an action and respect the sanctity of the non-separated mother-newborn dyad so that the first life-saving breastfeed can be done. We've been able to translate the now regional pocket guide into other languages, Cambodian, Vietnamese, etc. For the Philippines, we use the English edition in our training, and the second edition has already come out for the, so it's now WHO Pro 2022 edition is now out, okay? What are we trying to achieve? Basically, it's practice change. Mother and newborn should be cared for and monitored as a dyad rather than singly. So even nursing staff, they have to be integrated. Tasks need to be shared, okay? If the first embrace is completed in the recovery room after cesarean, or if it's completed in the maternity care ward, then it's those nursing staff that should also accept the task of administering newborn care, okay? So whether from the time of birth, you see here a mother at the moment of birth, no gloves on the baby so that the baby can smell amniotic fluid. Somehow on the stretcher, somebody put on a set of mittens, okay? But even as the mother is so-called co-bedded, no? We try to avoid a little roomed in because roomed in kinda for us implies that there was a non-separation, okay? So that when the mother is moved to her room, then the baby still, even in the stretcher, is kept with her. We emphasize that of the child survival strategies that were outlined by the Child Survival Group back in Bellagio, Italy in 2003, when they listed, when they estimated the protections, the benefits, the wonders of these preventive interventions at the top of the list of the public health interventions to save a child lives. At the top of the list was breastfeeding. And this is followed, of course, in endemic areas by insecticide-treated bed nets. But you'll see that of the top 3 preventive interventions, it really is our infant and young child feeding practices, exclusive breastfeeding starting in the first hour of life, exclusive until 6 months of life when complementary solids are started, up to 2 years or beyond while breastfeeding is continued. And we adhere to the IYCF. Even in pandemics, okay, so we stress, and Dr. Pam will talk about this, we adhere to the 4 core steps of Unang Yakap in both normal and cesarean babies. And here in picture are a hospital that we helped in central Vietnam that published the results of a COVID mother, despite being infected with COVID and being preterm, underwent cesarean section, even with her baby with oxygen, with supplemental oxygen, received the first embrace interventions, and thereafter succeeded in her breastfeeding, provided infection prevention and control measures were undertaken. In summary, this is what we talked about. We still are facing high newborn mortality here in the Philippines. Existing perinatal, what do we mean by that? Both labor and delivery practices and newborn care practices in the immediate postnatal or postpartum period still may predispose the newborn to increased risk of dying immediately after birth and in the first 1 to 2 days, if not the first week of life. But the 4 core steps in the immediate newborn care period can save lives, both mother and child, and facilitate the first life-saving breastfeed. Maraming salamat po. Many thanks.
Thank you very much, Dr. Silvestre. Can we ask our attendees to give a heart emoji for that well-explained a talk on the unang yakap. Ayan. So, heart emoji tayo dyan. Ayan. I think we were all in awe with the presentation and would like to circle around and check to see some of the questions that our attendees might have. If you have any questions, please do type them in if you're shy. But if you want, I would give you the time to really ask the questions yourselves. Dr. Silvestre, there was one question from one of our undergraduate students asking, is the unang yakap to be done as well for cesarean section mommies?
Yes. We've, of course, it has to be modified a little, right? Because unang yakap, of course, the most important thing that might differ is steps 2, early skin-to-skin contact, and step 3, okay, properly timed cord clamping. Remember the 4 core steps: immediate and thorough drying, skin-to-skin contact, almost simultaneous, then cord clamping, then non-separation for the first breastfeed. When you have the baby born out of the mother, okay, you can do the drying on top of the mother's thighs with the mother supine in the OR, correct? In cesarean. But you cannot do skin-to-skin, okay? Actually, in Australia, they actually tunnel the baby underneath and so that the baby can lie here and behind the ether or anesthesia screen, correct?
Yes.
In other countries that is done, they're tunneled through here, okay, so that the sequence is intact, drying, skin to skin. Believe it or not, the wonders of birth. The typical umbilical cord is long enough so that you can tunnel the baby under the scrub, you know, all the layers of linen, tunnel the baby here, and then clamp the cord. So it can be done. But as a public health measure here in the Philippines, not many are comfortable doing that because of the sterility questions, issues. So what we usually advise them is that you can interchange, okay? So after drying on the mother's thighs, okay, you can wait to clamp the cord. So second step is clamping of the cord at 1 to 3 minutes also, or even 5 if your anesthesia or obstetricians feel that it is doable. After cutting the cord, then you can transfer the baby to an unscrubbed or to another, or depending on your designation, the baby is brought out of the sterile area and then onto the breast area behind the anesthesia screen. And that's where step number 4 is done. Okay, so we have videos to that effect. We even have a video of cesarean section twins that were able to do skin-to-skin contact even in cesarean section. So the answer is yes. COVID or not
For that,
COVID.
Dr. Sylvester. Actually, I myself had a cesarean birth and I did experience the unang yakap done at the Adventist Medical Center, our sister hospital. And we were able to really do the unang yakap. I was able to do that. I guess that's also the reason why it was my third child that I was able to really fully breastfeed. Okay, there are still a lot of questions, but we have another speaker. Doc Mian will be joining us later, up until the end of our webinar, so you can conceptualize the questions, because I see a lot of questions, especially from the undergraduate students, Dr. Mian. I think you tickled their interest, and this is a very good thing because we want to plant the seeds of what is ideal while they're very, very young into the profession. Shall I now call who will be introducing? Ayan. Jimenez Domingos will be introducing our next speaker, who is coming all the way from Texas. And we understand the time difference, and so we would like to give her the time to share her expertise. Mr. Domingos?
Yes, well, thank you for the time. Now I will introduce Dr. Pam. Dr. Her complete name is Dr. Pam Sot, and her title is PSN and MPH LLC, EB, IBCLC. Currently, she serves as an independent health educator and lactation consultant, and she also teaches monthly brief breastfeeding class and consultant with moms on breastfeeding issue. And she is LISM certified. And she also have created several moms and baby educational tools for various hospitals. As a nurse educator, she writes in hospital orientation, registration nurse, OB teach pocket manual as well as numerous marketing pieces. She has also guided hospital to attain baby-friendly certification. She previously served in inpatient and outpatient care as a staff nurse in LD, mother-baby, and special care nursing. Become an international board certified lactation consultant, IBLCLC working. She has been nurse managed at 2 hospitals and intern the director CO of Southview Medical Center in Dighton. As per natal nurse educator, she served on the executive team in opening Catherine Health Networks Soin Medical Center. She helped hire, educate, and she set up the lactation program. She also graduated from the high school at Farm Eastern Academy in Singapore. It was here they realized that she wanted to serve in the health field. Dr. Palm earned her Bachelor of Science degree in nursing at Adventist University and a Master in Public Health with emphasis on health education at Loma Linda University. Among her many works, Dr. Pam was recognized as the 2013 OIN Nurse of the Year from Mars of Deans in Women's Centering for her work on development postpartum depression many shades of blue, which launching in the main village Oin region. Dr. Pam has service on many mission trips with legacy on health, healing, and Maranatha. Dr. Pam became certified health coach in 2018 with the Optivia program. She currently resides in Fort Florida with her life partner, Dr. Romsod. In her free time, she enjoys spending time with their two children and play pickleball. Well, thank you.
Thank you, Dr. Ma'am Pam. We are now ready to have you.
Hi, can everyone hear me okay?
Yes, we can hear you loud and clear.
Okay.
You may now
Thank you
share.
for that interview, introduction. And I just have to do one little thing. I do not have my PhD, so I'm not a doctor, but thank you for calling me a doctor. I appreciate it. Okay, I'm going to get to my screen and share this and start my presentation. And some of it will be just a little review again from Dr. Silvestris about skin to skin and first feed. But the more review, the better is basically what's going to happen. Okay, can we still show that up there? We're just getting this fixed here. Thank you. Okay, so basically, I just wanted to show people international breastfeeding sign, which is all over. You'll see it in airports and on airport pumping boxes. They have this sign, and this mom and baby is your international breastfeeding sign. So when you see that, you know breastfeeding is welcome here. So these are my two children. So I've had two and breastfed both of them. And my son, he is an architect here in Florida, and my daughter is a dentist in California. So I've come a long way with these. I've been a nurse for about 40 years. So it's just a lot of my experiences of what I'll be talking about today. And so as far as I have no profit. I'm not making it, I have a disclosure or anything like that. Everything I'm doing is volunteer. So I just wanted to put that out there. So as far as what I'm going to cover in the next 30-40 minutes is, and I'll try to go fast to make up some time here, is why are we breastfeeding? The COVID is a big thing. It's kind of less now, but it's still out there. And why do we do skin to skin? I'm going to fly through that because Dr. Silvestri covered that really well. And then the 9 steps that happen after birth, because that's when you know that, then you know when you should even offer breastfeeding after birth. And we'll just do a little bit of hand expression. I don't know if we'll go over a demonstration. What are the normal feeding cues of a baby? How can you tell? And breastfeeding positions. I'm just going to show you basically one because everyone has their own preference on that. And how do I know if my baby's getting enough? That's one thing that every single mom needs to know before they are discharged from the hospital. How do they know my baby's getting enough? And what is normal for an intake and output? So those are the things that I'm going to cover here real quick. Can you guys hear me okay? Yes. Okay. Okay.
Yes,
So why are we breastfeeding anyway? Well, the biggest thing is there's just tons and tons of reason, and I've just covered a few of them here. And I'm sure your teachers in your class are going to cover a lot more in detail. But bonding, it's that special time between mom and baby, and it really, really promotes bonding, breastfeeding, and you have that history for however long you're going to breastfeed. And the health benefits, there are benefits specifically to mom, specifically to baby, and they're just awesome. I mean, less cancers and less diabetes, more, some people say you're even smarter if you breastfeed. Well, I think that's a lot of environmental issues behind that. It's the perfect nutrition and easy to digest as far as when a newborn is born. And then breast milk helps baby develop their immune system because of all the antibodies, especially in that first milk, which is the colostrum. So there's a cost saving, and especially formula in some places you can't even get, and it's available. So it's huge if you can breastfeed and get this down. The risks of SIDS, or we call sudden infant death syndrome, where the babies end up dying for some reasons we don't know within that first 6 months. Statistics show that the risks of dying in those first 6 months are less if a baby is breastfed. And we are mammals, humans are mammals. So humans, our milk is species specific. All mammal milk is species specific. So cow's milk are for cow's babies. Human milk is for human babies. We are the only mammals that do not exclusively feed human milk to humans. So it's really kind of interesting when you think about it. Human milk is for humans, not cow milk. Okay, so what is the recommendations for breastfeeding? American Academy of Pediatrics recommends here in the United States, we tell every mom exclusive for a minimum of 6 months. That means just breast milk basically, and no formula, no foods, no cereals, that kind of thing. And continue to breastfeed for at least a year or longer if it's good for both mom and baby. So the WHO, the World Health Organization, recommends a minimum of 2 years. So worldwide, it's recommended longer than it is in the United States. So we talk about mommy-led weaning, that's in that first year, or baby-led weaning. So how long is a baby developmentally ready to wean? And literally, if you do the research on it, it's somewhere between 5 to 7 years if a baby weans themselves. So it's kind of interesting that we kind of put our little limits on it when a child really is not fully ready to wean, somewhere between 5 to 7 years. And sometimes you see babies only breastfeed if there is a trauma or they're hurt or things like that later on in their age. So next topic would be breastfeeding and COVID. So up to date, I'm just going to give you the bottom line of everything, all the research that's been out in all the different countries. Basically up to date, COVID-19 has not been detected in breast milk, even if mom is positive for COVID, not even suspected positive, but truly positive. So that is the bottom line. So if it doesn't transfer in the milk, it should be definitely okay for a mom baby to breastfeed. So if a mom is suspected or confirmed positive, you're going to keep mom and baby together, wear masks. If mom has symptoms, she's coughing, she's got a fever, things like that, wash the hands well before you're feeding or handling the baby, just precaution. So that is the bottom line. And that's what we tell everyone in our maternity. Keep mom and baby together, even if they're suspected, even if there are symptoms, they stay together as a dyad in their quarantine section. They can breastfeed all they want. And if mom is not breastfeeding, then if she is pumping, then, and she is not breastfeeding, then they can still give them up, but they have to stay together and the baby has to be giving. If mom is not breastfeeding, then it's better if mom and baby do stay separated until her 10-day quarantine is over. So, but we really encourage mom and baby not to be separated. So it's very rarely that we ever separate mom and baby. So if you want the latest, always go to the World Health Organization. I have the thing here, or your Center for Disease Control. They can give you the latest of any time. But as of now, keep mom and baby together and just use, universal precautions when you're feeding. So that is the nutshell of what you do with COVID. So for the students, this is a female breast, and basically I wanted to point out a couple things. So if you look at the nipple area, you see all these lines running through. Those are like the ends of the ducts that bring the milk out of the nipple. And then you have between 9 to 13 little tubes that come out of the end. Then you're going to have what, if you look at the inside here, I think of it as a tree. And sometimes I explain it to patients as a tree. If you turn this breast this way, then you have the trunk, that's your nipple. And then you have your branches, which is the ducts. And then you have all the hundreds of alveoli, which is leaves on a tree. And you can tell, you know, the mom, if you can think about it, that inside your breast, you have hundreds of these leaves and you have branches that bring it down to the trunk, and then the baby sucks it right out of the nipple. And sometimes they can get a visual of that. So when you are doing anything with the breast, the milk is made in the alveoli. That's where all of the receptor sites, and that's where the prolactin and the hormones come into there. So when you want to increase your, I wish I could ask a question, but my question to moms, every time I see them in a consultation, one of my first questions to them is, what makes milk? You know, they're like, this or that. The bottom line of what makes milk is an empty breast. You stimulate it, you empty it. If you do not empty it, then you will not tell that brain, oh, I need more milk. So you want to get more milk out. So think about and keep this little tree in your mind when you're thinking about, we're going to go through some things, how to get more milk and how to have milk come out. Think about all these little leaves and ducts way inside there. And looky, some of them go all the way back to the rib cage. So you have ducts all the way back. So when you're hand expressing and things, you're going to want to start almost always back to your rib cage and gently move that milk out to the end. So I always want to show this because it kind of gets in your mind, what are we doing and why are we hand expressing, and how is it coming out? And just a really quick thing, and I'm not talking about any problems today, but when someone says, oh, I have a plugged duct, what that is see the little branch? That's a duct. So what happens if you have a plug in your duct, the milk from the alveoli behind it does not have a way to come out. So that alveoli, that group of little cells, alveoli, will get bigger and bigger and bigger. And so mom will feel this big lump in there. So what is actually happening is the alveoli is getting larger because the trunk or the branch that's coming down, the duct that's coming down is plugged. So you got to get that plug out with heat or something like that before it will come out. That's just an FYI. So let's go to our next slide. So the hormones involved with breastfeeding are basically two. I always ask a million questions, so it's really weird for me not to be able to ask a question and get an answer back. But the first one we'll talk about is prolactin. And prolactin is the one that makes milk, and it makes it up into the pituitary gland, which is actually in the back of your head here. It's a little thing. So the prolactin tells your brain, okay, we need to make milk. The other one, I'm going to go back. The other one is oxytocin. And oxytocin, it takes about 2 minutes of stimulation from that nipple for the brain, the pituitary, that brings that oxytocin down to the alveoli, those little sacs, those little leaves in there. And then it coats around that, and it will go just like oxytocin does to the uterus. It pushes the uterus. It also pushes those alveoli, and that's when you have a letdown. It pushes the milk out. So the oxytocin is what lets the milk be available. It doesn't make the milk. Prolactin actually makes the milk inside of that little alveoli. So it takes two hormones. So I always ask mom, okay, when she starts breastfeeding, 3 things happen. Her tummy cramps, because then we know the oxytocin is there, and then I know it's going to push it out. she starts feeling a little bit sleepy because oxytocin is one of those, love hormones, and it's relaxing and it makes you feel good. And then the third thing is they get very, very thirsty. So I always say, before you breastfeed, get your cell phone and get a glass of water, get comfortable, get your pillows where you want them, and then start breastfeeding, because those three things should happen. And breastfeeding is going awesome if those three things happen. And the oxytocin is the one that most moms will, it hurts. Yes, it hurts a little bit. It's cramping, but I'm always glad. And I always like jump for joy, because when their tummy aches, I know things are working. And I know their uterus is contracting, and their chances of hemorrhaging more is less. So oxytocin is a good thing with breastfeeding. So you have two hormones. You might want to remember those, prolactin and oxytocin, and they both come from the pituitary gland. One comes from the front of the pituitary, and comes from the, I always remember the occiput part of the pituitary is O, oxytocin. So if that's a test question, you will know that the back of the pituitary is the oxytocin. So the occiput is the oxytocin. So it's kind of a little cheat sheet there. Okay, next, I always say moms and babies belong together. And this is what Dr. Silvestri talked about in Skin to Skin, because skin to skin is hugely important. Skin to skin monitors the baby's heart rate and all this. She covered so much of that. I don't want to review it too much. The benefits are calming. It releases those hormones that relieve stress, and it stabilizes their temperature, their heart rate, their blood sugar, and babies cry less if they are. And she talked about skin to skin. And you can see in this, it's always a naked baby, dried off. It's immediately after birth. Their cord can still be unclamped, but they're drying them off, and they put them on their chest, and usually they turn the head, and we, in our policy, says put 2 warmed blankets on top of them, and they will stay skin to skin until the first feed starts. And then we'll talk about when that's going to start. So it increases the prolactin. What does prolactin do? Make milk. So a mom that comes to my clinic is like her calling, I don't have enough milk. So then I just have them start immediately doing skin to skin, whether watching TV or laying at night or whatever in the day, put that naked skin to skin on there and cover them both. That increased their prolactin level. So when do we do it? We talked about it immediately after, until the first feed is completed. And it's the naked with a diaper on between the breasts, covered with warm blankets. And there are research over and over about skin to skin. Mom's chest, there's a speaker that comes from Australia, and I forget his name offhand, but mom's chest is made so that when baby gets cold, mom's chest will heat up. It's thermodynamic in there. They have all the research and the temperatures and all this. It's phenomenal. I was blown away by it. So put baby skin to skin on mom. Baby's cold, you put them skin to skin on mom, cover them up with blankets. Mom's chest warms baby up to a proper, and then if baby is too hot, then you'll see mom's chest cool down. Dad, on the other hand, doing skin to skin, it's a wonderful bonding thing. Do it, do it, do it. But dad's chest does not go up or down with the heat of the baby. So you just got to remember that. And sometimes dads are really get hot, and you get hot under the blankets. So you got to remember, you can overheat a baby, a dad can, versus a mom. Mom can stay under there for hours and will never overheat a baby. So it's phenomenal. I love that lecture. So this is what Dr. Silvestri was talking about. How soon do we breastfeed afterward? Babies go through 9 stages after birth, and some of them are a little bit longer so sleeping. So first one is cry, relaxation. And all of these are between 5 minutes to maybe 15 minutes. I have a whole grid if you really wanted, but then they go through awakening, then they move around and they rest. And some moms at the rest period, the babies start, familiarizing themselves, hands here or there. And it's not till step 8 of 9 steps that the baby even has a strong suck reflex. And that is usually between 40 to 90 minutes. So on her little question, she said 20, I think she said, I forget what she said minute wise, but it's usually about 40 to 90 minutes before that baby is even ready to breastfeed. So do what Dr. Silvestri said and just put baby on the tummy, no interruptions, no temperatures, no weights, no shots, and let them bond and get that baby. That baby was used to 98.6 degree inside, or I think it's for you, it's 37, somewhere in there. And boom, it's out in this world, and sometimes in an air-conditioned world. It needs time for its thermal regulation to happen before it's starting bombarding with all these procedures and things like that. So just remember, don't, like she said, don't force them on the breast. They're not ready. Watch their clues, watch their keys. Are they moving around? Are they moving their head? Now, if the baby is medicated and drugged during delivery, some of these things you have to look and make your own judgment on. But a baby that is not medicated, it's usually just wanting to go through all of these stages before it's ready. And that takes 40 to 90 minutes. So this baby is going to be skin to skin, mommy here, for 40 to 90 minutes. That's almost all of its recovery period. Okay, so why do we want them to feed in that 40 to 90 minutes after birth? We call that, that's their initial feed. Nothing happens until that feed is done. It helps contract, like we were talking earlier, that mom's uterus so they don't bleed as much. It is the strongest suck that that baby's going to have in that first 24 hours. That first 1 to 2 hours after birth, baby is awake, sucking, doing things more. Once it gets its feed, it's going to sleep for about 23 hours. And so throughout the day, the baby has a harder time feeding because they're sleepy. Day 2, then baby is awake more and want to eat, and you get on more of a regular system. So if you can get that first feed within that first 1 to 2 hours, and that baby sleeps the next 5 hours, we don't care because it had a wonderful feed. We know it fed well. Mom's got great colostrum. It's just sleepy. It has a headache from delivery. So those are the things that we do. So the other one is colostrum is high in those immunities. The very first day, it has all of those immunities really intensely in there when it first is sucked out because it has high concentration in there. And then the skin to skin gives the mom, you know, the baby warmth. It starts making hormones. So skin to skin, we talked about that earlier, it makes hormones so that mom is starting to make milk right away. And again, and everyone's talked about it, it introduces the family germs to the baby right from the very beginning, which is good. So like Dr. Silvestri said, you have milk immediately, even before the baby is born, and it is called colostrum, and it is high in protein. One second, it's high in protein. It maintains the baby's blood sugar. It's got vitamins, minerals. Immunity is one of the hugest things about it, full of antibiotics. It's concentrated form. It's designed for the first babies to help them sleep. Also, it's a laxative. So it gets that meconium. The first stool is a dark color stool. And with the laxative in the, I always have my little spoon. I don't know if you can see that. Maybe you can see it there. But I show every mom my little teaspoon, and it is, and you see the little yellow colostrum inside there, maybe right there, you can see it. And it's 1 teaspoon, and that is all they need to feed because of the tummy size. And Dr. Silvestri covered the tummy size really, really good. But I also have a thing in here, but I'll go over that in a second. So we have the laxative effect in this colostrum. Why do we want a laxative effect? Because inside that black meconium first stool, it has lots of red blood cells and different things. So the sooner we get that stool out, the more stools the baby has within that 24 hours, the lower its jaundice level is going to be. So we are like, the more colostrum they can get, the more stools that are out, then in that 24-hour, when we check their jaundice, I'm not sure if you guys check the jaundice level there. You do, the bilirubin, okay. So you would check that. So the more stools, so the more colostrum, the better they are off. So their milk will change over from colostrum somewhere around 72 hours. The books say from 2 to 5 hours, 2 to 5 days, you'll see that rise. And I love this slide. If you guys can see this, watch this. Awesome. So what this is when a baby is born, you see this, the pink line here is the colostrum in the milk. And so when the baby is born, they have lots of colostrum in there and very little of lactose. Lactose is a sugar water, it's a carbohydrate. So that's what all humans, especially humans with our brains, because our brains grow so much in the first year of life, we need lots of carbohydrates. So the lactose sugar water in there, around that 72 hours, you'll see the huge dip in the carbohydrate and in the lactose, and it mixes with the colostrum. So that is what we call around 72 hours, you start getting more mature milk. But what people don't know, and they ask, well, why are we breastfeeding so long? Why do you need to breastfeed past 6 months? Because you will have that colostrum, those antibiotic effects in there till you stop breastfeeding, till you no longer make milk. You will have that in there. And a lot of people don't know that or haven't been shown that. But I just love this. I got permission to use a slide from a friend. Anyway, so it shows what's in there. So how do we get started? Basically, if mom is not ready to breastfeed, there will be no breastfeeding. So we get moms ready first, get them ready, we get them comfortable, get pillows around them to support the baby and start hand expressing. So here's my little breast. I don't know if you can see the nipple there. Boom, there it is. And so basically we hand express, and I teach everyone, whether you are breastfeeding or bottle feeding, how to hand express, because everyone's milk's going to come in, whether you're bottle feeding, breastfeeding, whatever. And so if mom is engorged and she's bottle feeding, she still needs to know how to hand express some of the milk out to relieve the discomfort. So we teach, in America at least, every mother how to hand express. And so remember, inside here, all the way back to the chest wall, is all those leaves on the tree or alveoli. And then we have our branches that come down to the trunk that comes out. So what I have moms do is just put their put 2 hands on one breast, and they just massage a little bit at first. And just go on different sides. So they're going to move their hands to a different section so that they're pushing on different alveoli in there. I call them sacs. It's better if mom knows it. If you call them sacs, okay, I got to push on those sacs in there. And then gently, very gently, I just have them. It's kind of like I just use my little fingers, and then I slowly come out to the end and hold it there, and just leave it there a second and let that milk come down the branches, through the trunk, and out the end. Then lift it up, go to some more. You probably have to do this 10, 15, 20 times. The first time, if they have never had colostrum come out, or if they've never breastfed before, it takes a while to get that very first colostrum to come out. So then you just massage a different section and just massage a little bit, and then slowly just bring it out to the end and hold it and let it come down the pike. And then milk will start dripping out. And all I want moms to see is 1, 2, 3 drops. Because once they see the drops, I don't know how it does it, but in their head, then they go, oh, I'm making milk. And the whole thing just kind of turns on. So I always hand express before, and then especially the first 3 days until that milk volume increases. During, so before, during, and then after. So before is to get the milk to come out so the baby can smell it. Once she smells it, then she's ready to go. So she can smell it, she opens her mouth, she's ready. So before and then during. So we hand express during because the colostrum is thicker, it's harder to get out. And so if we just gently do this, those first 2-3 days, we are, remember what makes milk? The more you take out, the more milk you have. So by helping the baby those first 2-3 days when it's thicker, then you're taking more out and you're telling your body to make more. So then once you get hordes of milk in there, you don't need to keep squishing it or you're going to drown your baby. You know what I mean? So just gently do it. And then when they're all done breastfeeding, we hand express one more time, get 2 or 3 drops on there, and then she'll just rub it on here and then air dry it. And then because all those antibodies you just gave baby, now you put on the nipple to heal the nipple. Do that from the very first feed. Hand express before, during, and after. And if you teach mom to do that from the very first feed, then she will be able to have less pain, less sore. She sees that she's making milk, and it's just wonderful. What I do is I have mom put both hands on her breast. I put my hands on top of hers, and then I just kind of show her the feeling of how to do it so that she is doing it. She's touching herself and she gets the feeling of how to do it. That's what we call hand expression. So mom, you get her in her position, get her pillows, and then bring the milk out. Now we go get the baby. And then we wake the baby. And there are many ways you can wake the baby, but I think I might have a quick slide on that. We're gonna do as skin to skin as possible. If you undress that baby, put that baby skin to skin, even if they're not hungry, they're gonna start smelling that milk and they will start rooting around. So if they're not real hungry or not real awake, undress them, put them in their skin to skin, and they will start waking up pretty soon. So position the baby and look for the deep sucks without discomfort. That's what we're gonna, and I'll talk about that in a minute. And we're going to, by the time mom goes home, I teach them, what does a swallow sound like? Listen for the swallow, listen for the swallow before. So by the time she goes home, she knows how much the baby eats, how much the baby's gonna go out, what a good latch looks like, and what does a swallow sound like. Those are the things you really need to have mom know before she ever leaves the hospital, because you may never see that mom again. This is your, you have her stuck in a bed, so you can teach her as much as you can during that time. So we just went over hand massage, hand expression. I was a little ahead of myself. So go slowly, fingers, and keep repeating that and going back and forth. Stanford University has a wonderful video. I have it down here on how to hand express. Now, this is my little point, because they say put your fingers about an inch past the areola like this, push back and squeeze. That does not work the first time you try to get colostrum out. It does not work really well. Once mom is established with really good milk, that works great. You can just do that the whole time. But there are other ways to hand express, and one was what I just showed you. So if you want to see other ways, you can look at this video, which is very helpful. It really is. So how do we know if baby's even hungry? Well, it's the signs and symptoms. Look at your baby. The baby just woke up, or maybe the baby's still asleep and they're smacking their lips. They're just moving or just gently moving their eye. They're still in their REM sleep, and that's the time to get them up, kind of get them skin to skin, get them open. And sometimes their mouths are moving, sometimes it's not. So here you can see green is good. That's when you start. Yellow is, wow, you've waited way too long. This baby is crying, frantic. And you're going to have if a baby is crying, you cannot breastfeed, because you cannot cry and suck at the same time. So you have to calm that baby down, put them skin to skin, and then start breastfeeding. So try not to wait till your baby is fussing and crying. Those are late signs of hunger. The best time is you catch them right when they're waking up and stirring and their mouth is just moving just a little bit, and then grab them then and put them on. And then it's so much easier when they're not frantic-y. So we wake them. Number one, skin to skin. I've said that a million times. So did Dr. Silvestri. So remember skin to skin in your OB. And if you take your nursing skin to skin on your nursing test, is everywhere. So, okay, remove the blankets, take their clothes off. You can move their arms and legs around, talk to them, say their name, sing songs, do whatever, but avoid negative stimulation. That is when a baby will shut down. Shaking, yelling, loud music, stuff like that. They will shut down. And signs of overstimulation are they close their eyes, they fence their thing, they yawn. There's many different signs of overstimulation. You do not want to wake a baby that way. A gentle massage, those kind of things will help wake a baby up. Number one, skin to skin. So positions, and again, I'm not going to go over all of these, but we use a good thing to remember: when any position you use, baby should be a tummy to tummy or tummy to skin. So whether you're in a football, so baby should be at least the first few months when you're learning how to breastfeed, it's great to have tummy to skin. And then the head is aligned with baby's body. So they're straight. You can see in this picture how the head and the body are aligned. They're not twisted or head turned weird. The chin is, the nose and the chin are lightly touching. So I have my little baby here, and I don't know if you can see it. I'm going to move it up. So I say cheek, tip of the nose. So here is baby coming in. We kind of touch their chin a little bit, and they open their mouth and they go on. And then you should see, can you see that? Cheek, tip of the nose, not head scrunched in, but cheek, tip of the nose touching. I say that a million times, cheek, tip of the nose. And that means baby is in nice and deep. And, you know, the baby's just not sucking on mom's end of its nipple. That nipple then is protected. If she's in deep, it's protected by the roof of the mouth of the baby. So we want that baby in not shallow, but nice and deep. And then the nipple will be on. Okay, so hips flex if you want. See this first picture, how the knees are going up under her arms. That's a good alignment. So this is crucial. Bring the baby to mommy. Do not bend over and bring your breast to the baby. I don't care if you have to have 10 pillows, bring the baby up to you, and then you can be comfortable the whole time and you're not bending over. So get pillows, get in your position, and bring the baby up to you. And some people use fancy boppies and pillows, and my favorite is My Breast Friend. It's a baby pillow. It's called My Breast Friend, and it actually attaches with little snaps in the back, and it stays on, and it's wonderful. But you can use pillows, 2 or 3, and just get comfortable and have them there. So there are positions: laid back, cradle, cross cradle. I love football for the first week at least, because mom has a free hand. You can see on this top picture how her, even on the bottom, how her one hand is free. And so she can manipulate her breast and get a much deeper latch with the football hold. So if a mom is having a hard time, always teach her the football hold, because she will have so much. The bottom one is what we call cradle position. So she's going across mommy's tummy. But you can do cross cradle. If you look at the bottom picture, see how the baby's head is in her left elbow? So what you can do is take the right arm, put it under the baby's neck, then your left hand comes out, and you can actually grab your breast with your left hand there. And we call that cross cradle, because also mom has control of her breast that way, and she's holding baby with her right hand across the back and behind her neck. that's a good position too, but football is just way so much easier for a new mom learning how to breastfeed. And remember, there are no right positions. Everyone will do it their own way. Moms that have had C-sections, they love laying in bed, sidewise and doing whatever works for them. You have moms that are very voluptuous with large breasts. They may hang the breast over their leg and lay on the side. There's just all different ways that you can breastfeed. So signs of a good latch, I just told you one. Here we go. Wide open mouth. And then those lips are flanged. We call them in the States fish lips. So the lips are out, fish lips, and the full relaxed cheeks, they're not tight. You don't hear clicking, smackings, no noises. It should feel like a simple tugging, but not biting, pinching, none of those clicking, smacking sounds. So it's just sucking bursts and a pause. So they'll suck, 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 suck about maybe 4 to 6 times, and then they stop. They're breathing because babies are not coordinated to do suck, swallow, breathe all at the same time. So they will suck, 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 stop, take a breath, and then go back at it again. Suck, swallow, breathe. That doesn't happen for a few weeks. They don't have that coordination. So that is a good sign. And I always tell mom, again, you saw it earlier, cheek, cheek, tip of the nose. Baby's on, and it's cheek, cheek, tip of the nose. I don't know if you can see that from there, but okay. So let's go here. And this is mine in America. We use a cherry and a walnut and a apricot and an egg. It's almost identical what Dr. Silvestri showed you. And what I have in my pocket at work is on a chain. Oops, there we go. On a chain, I have my colostrum spoon with the colostrum in it, and I have my circles. So here we go. Here is the newborn tummy size, and the stool. Look how dark it is. That's the meconium. And then about 3 days later, then you're gonna, so this is about 5 to 10. And what she mentioned was excellent about telling your moms, your baby's tummy is the size of a marble, is the size of a small circle, and it can only take about 5 to 10 milliliters of of breast milk. So, tell them that. And I show them this, every mom that I go and see, so they actually see. So what they are producing is enough. And then they don't worry that they're not going to have enough. So that's about 5 or 10. And then around 3 days, it's going to get lighter because that milk now is into the system and they passed a lot of that meconium. And then they can take more, about 30. So see, when those little bottles that were on Dr. Silvestri's are 2-ounce bottles, that's 60 milliliters. So at around 3 days, they can take 1 ounce, which is about 30 milliliters. And then about a size of 10 days or so, about 5 days, you should start seeing that stool turn. We call it mustard, running mustard with cottage cheese. That's a fabulous breastfeeding stool. And this is about 10 days. So they can be at about 6 to 10 days, they can be up to about 60 milliliters. So this is what I show mom. I carry them in my pocket all the time. So they have a visual. So they have a goal on what they are feeding their baby when they leave the hospital. So these are really cool. I got these, I ordered these. I think it was at, what is it called? Childbirth Graphic, I think it was. I can find out exactly later, but Childbirth Graphic carries them and they're wonderful. Okay, so how do we know? And how does mom know when baby has enough? So I always say, what goes in has to go out. So by their pees and their poos, are they sleepy? How do they look? Those kind of things. So the number of feeds that they're going to have in that first 24 hours is somewhere between actually around 6 to 12, depending on the baby. That's what they can take. So are they having enough input? Are you hearing those swallows? You probably won't hear them the first day, but by the time they go home, they should be hearing swallows. And then what does their urine look like? Is it pale or is it concentrated? That's the same with adults. So they should be having, by 6 days, they should be having at least 6 P's every single day. So stools 3 to 4 by day 3 to 4, they should be having like 3 to 4 day stools until they're about 2 months. Then stools will lengthen out. They won't have them as much. And the big thing, and I'm not sure if it's so much overseas, but the weight loss percent. We do not want the baby in the first 2 days to lose more than 7 to 10% weight, because all babies lose weight, but we don't want them to lose that much weight, because then they have to catch it up, and then they will not be back to their birth weight at 2 weeks. So the goal is back to your birth weight by 2 weeks. So they lose for about 5 days. But if a baby in the hospital has already lost 7 to 10%, they have 2 to 3 more days to keep losing weight. So then they will be losing too much weight. Then they level out, and by 2 weeks, they should be back to their birth weight. So we kind of want them not to lose so much at first. Is the baby content? Here's my little milk drunk little kid here. He is definitely full and content. And the big thing is, what do your breasts feel like? Do your breasts feel like they've been emptied? Or are they still hard or full? They're not always hard when they're full, but are they full? So in the hospital, we have a little booklet, and we give this booklet out, and inside of the book, it has a grid. So I don't know what you give your patients when they go home so they can keep track of it. There are many apps, you can do it on your phone and those kind of things, but here's a quick little diary that we give. You know, it gives you your goal on day 1, it's 6 to 8 feedings. And then, so I see the little blue, there are 6 spots. So you put the times of the feedings, and if they're on the left side or the right side, and here's your output. So on day 1, see the blue, there's only 1 blue square, and that's for urine, and then 1 for stool. And then you go down to day 2 and see we've added more because now they're more awake and they can do more. But by day 2, you need 2 P's and 2 poos. Day 3, 3 P's and 3 poos, and it goes down the list. And so they have something to follow when they go home. So I'm not sure what you use, but this is what we give. All hospitals will give them some form of information. So cluster feeding, what if they feed now and an hour later they feed again, and an hour later they feed again? That's normal. That's totally fine, because then they may sleep for a 5-hour stretch. That's okay, because they fed real good and real good and real good. So moms think, well, they're feeding all the time, I don't have enough milk. Well, what are they doing in between? If they're feeding every hour, 24 hours a day, maybe. But if they are feeding 20 again and then again, and then they have a stretch where they sleep for several hours, they're content. So that is not a low milk supply issue. So how long do we feed? We say you pick your side you're going to start with, and then you feed on that till baby kind of goes similar to sleep. To wake them up. Sometimes I like to change the diaper in between breasts, because then you put them on the second breast and then they just feed till they go to sleep. It might be a minute, it might be 10 minutes. So next feed though, start on the, the side you topped off on, and then feed them as long as they want, and then change your diaper in between and go to the next side. And so you alternate starting sides each time. And some moms at 2:30 in the morning, they don't know how in the world, what side did I start on, this and that. So some moms will use like the twisty in their hair, they'll put it around their wrist. Oh, there it is. Okay, I feed on this side, switch it. So just whatever they want to do, they can switch sides and remember what side they started on. Okay, so we don't put time limitations on it. Some people say 30 minutes here, 10 minutes here. We never put a time limit in. What we do look for is how long they have fed, and what is their routine. If by 3 weeks they are going longer than 50, 60 minutes, an hour, every single feed, something is going on. So we like to see a feed somewhere between 5 minutes to 30 minutes. That's a good feed, and it varies every single one. Sometimes we eat a 5-course meal. Sometimes we eat it a snack, so it varies, but you just look to see how they're doing. So no limitation of time, but how long are they going? And most babies will not ever overfeed. They have a cutoff and they stop when they're done and they fall asleep. So what makes milk? Supply and demand. What makes milk? An empty breast. Get that milk out and then you will make more. Communication, mom and baby, it sets it. Supply and demand. Okay, it's important those first few days to get the pattern going, those first few days. How often do I need it? And I just wanted to let you know that some people say, well, they're sleepy the first day and it's not important. And I heard Dr. Silvestri say that they don't get some of these babies to the mom till day 3 after a C-section. That's pretty sad, because most milk is set. You have receptor sites inside your alveoli in the breast. And in those first 24 hours is what you're adding. So the more you breastfeed in that first 24 hours, the more receptor sites you've set in those alveoli, and it prepares you for the future of how much milk you're going to be making down the road. So it is crucial that you breastfeed, put that baby to the breast as much as possible. That first 24 hours to get those receptor sites in there and starting to make more milk. We do, especially those first 3 hours, 3 days, avoid extra pumping, because if baby is doing really well, you're emptying your breast, then on top of it, you add more pumping, emptying more. Then when that milk volume goes up, we are going to go way up and then now cause engorgement and other problems. So really, really try not to do any extra pumping, especially in those first three days, unless there's a history of low milk supply. Then I would start mom pumping after the first feed, day 1, first time, just start pumping her after the feeds, if she has a history of low milk supply, but you don't know that right away. So, and avoid any supplements, because anytime you're giving baby something that you are not making, then you are not making it. So you're not telling your body to make it. So you've already you're a little bit behind. So we encourage no supplementations at all either. Okay, and here's your normal stooling. We talked about the meconium, dark, get it out of the system so the bilirubin goes down faster, and then transitions day 3, 4, you get more of the greeny brown. And then by day 5, 6, 7, the more breast milk you get in there, then you're going to see that yellow. This is our mustard, runny mustard with cottage cheese. That sounds disgusting, but that's what a good breast stool is. Okay, so this is my biggie thing. Put the baby in the kitchen and they will eat. So here it is. Skin to skin, make sure the baby's naked, wake them up good. Get that asymmetrical latch. I didn't talk as much about that, but I'm sure you'll hear about that during your classes. Compress the breasts while we're feeding and listen for that suck and swallow. We talked about all of that. So put the baby in the kitchen and they will eat. That's called snacks. So that's my little. So here is the original Happy Meal. I don't know, you have McDonald's over there. So this is the original Happy Meal. So I just love this little poster. It's awesome. And then, so if you guys, everything that I've said, I have references and stuff for, but I just want to give you some information, some fun books to read about milk and making milk and how it's made and covering things. There's some great videos. Jack Newman does a wonderful guide on it. The Leche League, they are our guru here in America on things. They have books out, they're wonderful. And we have a group called kellymom.com, and she is really research based, and all of her stuff on her site has been proven and researched. So many lactation, go to kellymom.com, and it's just great information there. You can go to their search and put what topic you want, and all the different articles that she has on there will pop up, and it's really nice. And you can even have your patient go to that site and say, go to here, look up this, and print it out. Stanford University, like we talked earlier, has tons of videos on different things. They have how to start, how to hand express, good latch, caring for a premature baby and breastfeeding. So it's a really good site to look at too. So I'm done. I talked really fast to catch up some time, but hopefully everyone heard all that.
Thank you so much,
So,
Pam. That was a wonderful presentation. It's very nice when we are able to break down breastfeeding into something workable and doable, because as a lactation consultant myself, I see a lot of concerns that are answered by the discussion that you have had. And one of the things that I love the most is your discussion on how babies regulate when placed on mommy's chest.
isn't that
Thermal
awesome? Yeah,
synchronicity.
thermal regulation.
Yes.
That's what they do when they're on there, and it's amazing.
Yes.
I will, if I have your info, I will look up the guy who gave the lecture. It was phenomenal. So
Thank you. Thank you
good,
so much. You
good.
know, Pam, in the Philippines, there are only roughly around 22 IBCLCs in the country. And we're
Wow.
hoping through this webinar, we espouse to this future nurses and the nurses who are practicing right now to look into the prospect of becoming lactation
That would
consultants.
be awesome. Yeah, that
Yeah.
would be awesome.
So at
Good.
this point, we will now, I understand it's late in the evening there from where you are from. So I would like to ask the attendees if they would have any questions for Pam before we let her go. As much as I would want her to join us, I
Yeah.
don't want her to stay up late because of us. But are there any questions in the chat box? There are some questions, Pam. Maybe perhaps, oh, there's one. Okay, let me get this one. Mothers complain they cannot do the S2S because they are too groggy from anesthesia. So how do we handle the skin to how do you facilitate the skin to skin for
Well,
moms
if
who are sedated? Yeah.
if a mom is medicated and there is no other family member in the room, we cannot do skin to skin and leave a baby with the mom that's groggy. That is unsafe. But most of the time they have family member in there. So we put them in there and we put them skin to skin and we're watching, and the call light is right there. And if there is any issues, then you family member will call, and a nurse during recovery stays at the bedside at least for the first hour. So there is somebody in there working with them. So there is, there's people around, at least with us. Now, see, I don't know the whole system there, but we usually, it's safe. Even we do skin to skin right in the OR. And now I would say not every single hospital in the United States does, but more and more and more and more. And all the hospitals where I came from did, because, like she was mentioning, once the cord is cut, and a few times the cord wasn't cut yet, they just bring them around the curtain and they tuck them in there, and we have warm blanket warmers, and we put all those warm blankets on them, and they're right there in the OR doing skin to skin right there. And a nurse is there, they're watching the color, what's going on, is the baby breathing? You can take the baby's pulse, their brachial pulse, when they're right there on the chest. And then after things are going and they're closing up mom, we usually put the baby over to the warmer, do a quick assessment of them, dry them off really good. And then when mom is ready to go to the room, that baby stays skin to skin during recovery. And we encourage moms that have C-sections, they have more problems with milk coming in. If you have a C-section, for many reasons, high intake of fluids during delivery, blood loss, you name it, that goes on and on. But so it's crucial that C-section moms keep that baby skin to skin for the whole next 3 days. If I had my way, that baby would be skin to skin for 3 days before they went home, because they will be making so much more milk. So
That's the same
especially with the
experience.
C-section.
Yes,
Yeah.
that's the same experience I had being a C-section mom to my youngest child. I was fortunate to be able to do the unang yakap, or the skin to skin, the EINC, which Dr. Silvestre discussed earlier. And I
Yeah.
think that answers the common question: will I be able to do this if I am C-section? So I guess the answer there
Yes,
is
you should.
yes, very much. You can do it
Yes.
despite the
And you
C-section.
want, and after you get in recovery, you want to do it, really make it a conscious effort to do it.
I,
So,
I
yeah,
think our role also as nurses is important in that we educate our moms to be early on, even before they deliver. I
deliver.
think it's the prenatal part of the education where we can discuss to them that these are the
Absolutely.
things that you will be expecting. And
That's exactly
there's
right.
literature that says moms who are educated about the birthing process, the initiation of breastfeeding, tend to keep into breastfeeding because they were equipped, and they can state it in their birth plans. You have it in your country, birth plans. How does it go in your country?
For what is that again?
Birth plans. Mothers
Birth
are,
plans. Yes,
yes,
we have birth plans, but each person's birth is so different, and you have different hospitals, different doctors, and you get a different nurse when you come in. So yes, you can bring a birth plan in and people make the birth plans, but most of the time their birth plan doesn't go exactly how they want it, exactly how it's written, and they make their own as they go. So I personally, when I worked labor and delivery, you don't see that many birth plans, because they take a class before, they kind of know what they're doing, and they, talk with their doctor beforehand. They do a tour of the labor and delivery. They already know a lot of stuff, what they want. So, and when they are admitted, then they tell their nurse, okay, I would like to cord, this or that. I want to be at bedside. I want so-and-so in the room with me. So you do a one-on-one thing with your nurse, usually when you arrive to the unit. So I don't see a lot of written plans anymore, but they're out there.
yes. There's a question earlier. I think both you and Dr. Silvestre may be able to give us your insight. One question is about lotus birth. Because as lactation consultants, and maybe perhaps Dr. Me and Silvestre as a pediatrician, a neonatologist, can share with us your thoughts about lotus birth, which apparently is one of the practices that are being done. To those who are in attendance who might not be familiar with lotus birth, I think lotus birth is delivering and there's non-severance of the placenta for extended numbers of hours or even days, and they just wait for the placenta to be shed off. So I don't know if you have encountered this in your practice, Pam and Dr.
It,
Silvestre.
well, as far as in America, we do not do that regularly at all, only because you have the babies when the placenta, like she talked about, when the cord stopped pulsating, which when in America, we usually cut the cord after 60 seconds. That's our routine. That was what was in our policy, 60 seconds. So that's 1 minute. And so when the cord stays on longer, then babies get more of maternal blood in there, and we find babies afterward higher jaundice levels, higher, we call them the red babies. They look really red because they're full of all these extra red blood cells, so it makes their jaundice level. So we do not practice that routinely in America.
Yes. Dr. Silvestre, what is your take on lotus birth?
Thank you, Marjan. Thank you, Pam. I think all the questions are kind of interlinked. I work now, I'm no longer a clinical neonatologist. No, I gave up private practice more than a decade ago, and I now work in health systems on health policy. And in fact, everything that we changed in terms of health policy for birthing, we tried to base on evidence so that we could change the behaviors of our obstetricians, of our anesthesiologists, of our nurses. And one time on a Facebook page, I posted about the evidence for so-called delaying cord clamping. And because of the evidence from a local randomized controlled trial comparing 1 to 3 minutes and 3 to 5 and beyond 5, we found that 1 to 3 minutes is already optimal to prevent anemia. So it's harmonized with what Pam was saying, that their policy is 60 seconds minimum. Is that correct?
And I've
Yes,
seen
60
also,
seconds.
I've seen some hospitals say 1 to 2 minutes. So it gives
Yes.
that little thing in there, but.
Yes. And the reason why I'm explaining that I'm in health systems now is because arising from that, my post on Facebook, I was I received a comment from a midwife from another country that called the practice ridiculous. Okay, literally, she said that's ridiculous. Why clamp and cut at 1 to 3 minutes and etc. etc. Of course, as a neonatologist, and Sam alluded to that, the ruddy red babies, and of course in neonatology, there's a subgroup of babies that might even develop hyperviscosity. So
That's right.
the blood starts to sludge and clot it excessively. So, but it's usually the babies that have problems in the uterus, the small for gestational age, growth restricted babies. Anyway, to make a long story short, that's what we've been trying to do, is to standardize health practices so that even the exceptions are also protected, okay? So we explain that we don't have the evidence of the harm for not severing the cord, okay? For allowing the placenta to just dry up beside the baby. And another perspective is that we're even having a hard time convincing obstetricians to wait a minute.
Oh, I know. That is our biggest problem. So if we make it to 60 seconds, we're lucky.
I know. So to change behavior on a population level, just imagine if we have to go to something as esoteric as not clamping and cutting the cord. So it's a rather esoteric practice. It's a kind of what's a Tagalog word for esoteric? Medyo how do you say esoteric in Tagalog, Marge? It's an outlier practice.
Outlier, yeah.
So to change behavior on a national health policy basis is very difficult. Even asking for 1 to 2 minutes, even 3 minutes, is such a big thing to ask for obstetricians and midwives and cesarean in busy delivery areas. So
right.
I just answered that and in the same token, to require small health centers in islands to do water birthing and non-severance and all these rather outlier practices. We're not pushing these outlier practices as of this moment. So I hope that that's a rather safe and political answer. The scientific answer is we don't have yet the evidence of safety.
Yes.
Because
so it's always evidence-based practice, Doc Mian, and we go by that.
And local evidence, judging by the context in which these practices can be held. I do know that some doulas, Pam?
Yeah, doula.
Some national doulas, local doulas, they do promote water birthing and lotus birthing, the lotus being placenta.
Water births have actually increased in America. They were up, like 10 years ago, and then it was no. Yes. And then now things are getting a little more, we have more doulas in America. So you have more, people at the bedside helping the birth. So they are willing to do more things. Now, most doctors don't do water births, but doulas and midwives and all of that. And we have more now. And so we're seeing a little bit more of those. And so labor and delivery units have, like we call, disposable pools that we blow up and fill up with water and have a thermometer in there. But they deliver in jacuzzis. So a lot of jacuzzis are in labor and delivery rooms. And so we deliver in those, but it's not a common thing.
Yes. And because I'm in health policy now and health systems, imagine pushing for water birth, but health centers on islands, they don't even have toilets.
No,
Yeah.
no,
Swimming pools.
I would not, I wouldn't go there.
So I hope that blanket answer kind of covers for all these other practices that we know are in practice now, but usually they're confined to very how do you say this, resource rich settings like exclusive hospitals. So it's all context here in the Philippines, and right now we can't push for these on an official health policy basis. Thank you.
Yeah,
Thank you, Pam. Thank you, Dr.
Yes.
Silvestre. I think having a discussion on the evidence that are present, we always say to our students, both in the undergraduate and graduate levels, that we do our practice based on what the evidence tells us. So this also paves, opens the door for them to look into this as something they can research on, and perhaps in the years to come they will be able to share with us what the evidence tell us so that we can shape the healthcare systems.
The pain
Yes,
relief, especially with water birth, is a huge benefit. But
Yeah.
but pushing water births at a national level with all our remote areas and poor areas, it's a different game. It's a totally different. And our country is poor right now. It's really in debt.
So thank you. Do we still have questions for Pam before we let her go? Because I understand it's late already in her place. I see none. Dean Hael says, Ma'am Pam, truly we appreciate your sharing of very informative critical points for nurses to remember and apply. Thank you for your valuable time and expertise. I think before we let go of Pam, as it's late already, may I request everybody to turn on your camera so we can take a picture together with the speakers complete before before
I'm gonna do
yes.
mine too. Yeah.
Yes, let's have, so you, everybody, all the attendees, please open your cameras and let's have a photo op moment. Yan. It's okay, we're so used to the work from home appearance, that's fine. Nurses always look good wherever they are, so that's fine. So asking everybody to open your cameras, I will take the
Five
picture.
galleries.
Yes, there are 5. Okay, everybody smile. I'll take the first page. Ready? 1, 2, smile. Okay, that's the first page. Let me go to the next. Okay, students. Yan. We welcome the undergraduates. Ready? Smile. There. Okay. Let's go to the next page. Okay, everybody say first embrace. Ready? Smile. There you go. And then the fourth page. There. And the last page. There we have it. Okay. So thank you so much. Thank you. Are there, okay. One of our faculty, Ma'am Arit, said, very informative presentation. Thank you, Dr. Silvestre and Miss Pam. If there are no questions, then perhaps we can call on Chelsea, Dr. Orbe.
Certificate.
Okay. So where's the, there. So before Pam goes, Dr. Orbe, would you like to present this, being the head for the class?
Thank you so much, Dr. Ma'am Pam or Dr.
Yes.
Pam, for joining
Yes.
us.
You're
Your-
welcome.
Yeah,
Will somebody send me this certificate in an email? That would be wonderful.
yes,
Thank
we will
you.
send you. Your presentation surely was insightful, especially on the practice of our clinical instructors as they supervise our students in the clinical area during deliveries of babies, not only in hospitals, but we are also covering up deliveries in the lying-ins. So
Mhm.
this practice would truly enhance the persons and the practice where they are as they open their minds to new evidence-based practices and put this into what our students would be learning and seeing also in the clinical area.
It's
So
awesome.
yeah,
I have a whole lot of what ifs, the problems, the mom's problems, baby problem, but that's another whole lecture.
yeah, maybe we'll have another part two of this.
Yeah, part
In,
2. There you
MC.
go. Well, you guys have a good day, and we're gonna go to sleep. So
Yeah,
goodbye.
okay.
I'll talk to you later.
Yeah, let me
Okay,
just
thank
read.
you.
Yes,
Thank you.
let me just read your certificate. The certificate of
Okay,
appreciation is
okay.
proudly presented to Palm Seller Stout, BSN, MPH, LCC, and IBC.
LC.
ELC.
In grateful acknowledgement and sincere appreciation for having served as resource speaker in the Nursing Graduate Studies webinar of the course Growing Family with the theme The Persons and the Practice, Maternal and Child Nursing Perspectives in the Now, the New, and the Next Normal, given this 8th day of December 2022 at the Adventist University of the Philippines, Puting Kahoy, Silang, Cavite. Signed by our project coordinator, the leader of our graduate school batch for Growing Family, Mary Manuel, who is a registered nurse, the professor, yours truly, and of course, our Dean of the College of Nursing, Dr. Susie Hael. Thank you so much.
Thank you. That was very, very nice.
God bless
Thank
you.
you. You guys have a great day.
Thank you.
Bye-bye. Bye-bye.
Moving forward, shall we now call one of our students? Kelsey.
So I have the honor of introducing Dr. Maria Julita Sabayan. So she is an assistant professor and clinical instructor at the Adventist University of the Philippines and teaches both in the undergrad and graduate level. In practice, Dr. Sabayan is an international board certified lactation consultant and certified breastfeeding specialist. She currently serves Sigma Theta Tau Honor Society of Nurses Phi Gamma chapter as program director and provides guidance to the chapter's Care and Restoration of Infants Crusade through breastfeeding and breast milk banking. She was recognized as the chapter's academic achievement scholarship and was one of the rising stars of research for the 45th Biennial Convention for her research work on interprofessional education. Her personal ministry, advocacy, and expertise has led her to serve various non-governmental organizations, such as Advent Moms, Arugaan, Kalusugan ang Mag-ina. She is a Smile Train partner, an international children's charity that supports 100% free cleft repair surgery and comprehensive cleft care for children globally, and recently was elected one of the Philippines' country representative for International Baby Food Action Network, or IBFAN, a public interest organization working around the world to reduce infant and young care mobility and mortality. Dr. Marge is a full-time working mom to 3 lovely children whom she shares with Dr. Kenneth Sabayan, a pediatrician and breastfeeding medicine specialist, and the other half of Baby Doo-Doo Docs, child health and breastfeeding care specialists, an online and in-clinic service provider for pediatrics, breastfeeding, and lactation. May we now listen and welcome Dr. Marge as she shares with us.
Thank you, Kelsey, for that intro. I will try to talk as fast as I could To our students, we were talking about breastfeeding from the start. Now we will be looking into a special population, cleft babies. Okay, there's one question. There was someone who messaged me, Ma'am, paano po pag may cleft? How will it be done if somebody has cleft? And so I'm sharing my screen now. Can you see my screen? Can you see it? I hope you can. So my talk will be on the limelight, on the algorithm of cleft nursing care. That's why I said, papunta pa lang tayo sa exciting part. Okay. Oops, wait, let me go back a bit. So as a disclosure, I declare no financial relationships, past or current, with entities that manufacture and distribute tobacco and alcohol products. Okay, any,
Mama Arch,
yes,
excuse me.
yes.
You're not your screen is not seen online yet.
Okay. So wait, let me get that. Did it show already? Not yet.
No, I think you should relaunch it.
Okay, let me do that. Whoa. Let me, wait, I cannot find my screen. Okay, let me go back.
There we go.
There, it's there. Okay, I think it's just a bit delayed. Okay, so now you can see it?
Yes.
Yes,
Okay.
yeah.
So, as I was saying, okay, I have no financial relationships with any breast milk substitute baby foods or any products covered by the EO 51 or the Philippine Milk Code and International Code of Marketing of Breast Milk Substitutes. The photos of patients presented, that will be presented, were taken at the Baby Dudu Doc's Health Clinic, okay, and our patients under Smile Train, okay. Virtual and in-clinic feeding and nutrition services for cleft are funded by Smile Train Philippines. Okay, can you see my slides now? Okay,
Yes, Marge.
okay. So aerodynamically, the bumblebee shouldn't be able to fly, but bumblebee doesn't know that, so it goes on flying anyway. This is an adage made popular by, there are two names that come out every time. This is mentioned, okay? One is Mary Kay Ash, and another one is Andre Saint Lad, okay? The adage, the bumblebee shouldn't be able to fly, was based on the calculations using aerodynamic theory in the 1918s to the 1919s. No? That's around 15 years before the Wright brothers made the first powered flight. This early theory suggests that bumblebee wings were too small to create sufficient lift. But since then, scientists have made the huge advances, understanding aerodynamics and how different things work. Okay, I hope you can see the video. I cannot see it from my end, but are you seeing the bumblebee that flew over to the flower in the slide? Did you see it?
Not moving.
Did not move.
Photo lang.
Maybe
Yeah.
it's the internet. Anyway, so let's move on. Okay, so I want you to meet Smile Train baby C. You see this baby has unilateral cleft lip and palate. Okay, at the time of the consult, okay, mommy was struggling to allow her baby to breastfeed. So let me play this video. I hope it plays out from your end. Is it playing? When I tried this yesterday, it was playing. Okay, but here you can actually see the child suckling, supposedly. Okay, I do not know why this isn't playing. But it's,
Marge,
yes,
can you try turning off your video? Sayang yung film.
wait lang.
Sorry po, nag-i-interject ako.
It's okay, it's okay daw. Teka lang
Sayang
po.
yung videos eh, oo.
The thing is, I cannot see my Zoom.
You're
Now that,
on. Can you turn off your camera?
let me see po. I couldn't see myself. Wait lang po.
You're still on. Oo. Turn off your camera. Sayang yung videos. Sayang yung beauty mo, pero
Okay lang po, wait lang ah. I think I need my daughter's help. Daughter, can you hear me?
Lower left, turn off your
Wait
video.
lang po ah.
Turn off your camera.
Oo, sayang kasi para makita po nila yung video. Wait lang po ah. It's my first time using Canva as well, so medyo foreign po siya sa akin. Wait. Nicole? Maski yung controls ko na Zoom, hindi ko po makita. Wait lang.
Mouse at the top.
Ah, there.
Mouse, yan. Turn off your video. Sorry ha.
Okay
Sorry
na po.
po.
It's okay.
Yan, you're off.
Yeah. Sige, balik tayo ulit. Tingnan ko nga kung mag-play.
March, nawala yung screen mo.
Nawala yung screen ko. Wait lang po.
Tama po ba ako? Dean Suzy, nawala yung
Yeah,
screen.
I cannot also see the screen.
Wait lang po. Let me stop share. Let me figure this out. Sorry.
You can play the video separately.
Cannot see your screen, Marge. Sorry, ako pa yata nakasira. Marge, nawala yung screen mo. Are you still there?
Yes, Doc. I'm still here. Ayan. Hindi na lang ako hindi na lang ako magdudual, yan. This one. Ayan. Can you see now?
Yes.
Yes.
Kita na po. Yan. Tingnan natin kung gagalaw. Hindi pa rin gumagalaw siya. Wait lang.
Hindi ko rin kabisado ang Canva.
Opo. But the video isn't working from my end. I wonder. I don't know why.
Can you slide it back to the, rewind it? Slide the play button backward.
Sige po, Doc. Yan. There. Yan. Okay na po ba?
Yan.
Ayan, gumalaw na siya. Okay. Sige. So, balik natin ang slide. Hirap po pala ng techno stress. Ito po yung first video that I wanted you to see.
Yeah.
Yan po si
Flying.
Bumblebee na gumagalaw. Can you see it?
Yes, flying na siya.
Okay. So, sabi nga kanina, the bumblebee shouldn't be able to take flight, but it is able to do so. And so, here in the next slide that I'm showing you right now, you can see the baby actually breastfeeding despite the cleft. Kita niyo po ba? Can you see it there?
Yes,
So that,
moving.
Yes, Marge.
so that proves to us that babies can breastfeed. No? I think it was stressed a while ago by Dr. Silvestre that babies are born with pre-programmed reflexes that allow them to breastfeed. So they do not come out of the mommy's womb conscious that they have cleft. As far as they are concerned, if they smell the mommy's breast, if they are put in their mommy's chest, their job is to latch on. So most of the time, it is from our end, tayo yung nag-overthink na, maybe this baby will not be able to breastfeed. Okay? And it is important that as nurses, we are able to facilitate this wonderful thing that is breastfeeding, despite some challenges, such as the cleft that we see in this slide. Okay, the points that I will be sharing come from the experiences I have had as a clinician from the time I started working with Smile Train. As you can see, starting February 2021, as a clinician, I was able to have 191 cleft consults, 139 of which were virtual, 16 were pregnant. Okay. 52 in clinic, and 187 of those consults are cleft lip and cleft palate babies. There were only three clients who had purely cleft lip and only one baby who had only isolated cleft palate only. No? 22 out of the 52 in-clinic consults came back. Usually, I would see them for an average of 2 to 3 visits. And based on the consultations that I have had with them, these families, okay, these patients, main concern, of course, would be them having cleft, okay, um, how will they be able to manage the care of babies who have different needs? How will they be able to have their breastfeeding? How will they be able to feed their babies other than direct breastfeeding, which can be challenging because of the anatomic differences? Okay, is it possible for them to relactate after realizing the value of breast milk that can never be replaced by any commercial formula in the market, considering that their child has unique health needs? Okay? How about slow weight gain concerns, which is common for babies who have feeding difficulties such as cleft? Other concerns that we see would be anything related to gastrointestinal problems, diarrhea, respiratory tract infections, and skin infections, which are health concerns that are common to babies who are formula fed. Okay, as an infant feeding nutrition and feeding specialist, complementary feeding is also one of the things that we have to address. No? When the baby hits 6 months, how will they be able to feed their child? And this is where we discuss complementary feeding. Okay. Now, top nursing diagnoses for cleft patients, and I'm sure everybody can relate to this, would be number one, deficient knowledge. They don't know how. Okay. Willingness to improve parenting are common nursing diagnoses that I see: ineffective breastfeeding, interrupted breastfeeding, risk for nutritional imbalance, risk for effective airway clearance because of the cleft, risk for aspiration, especially with the use of bottles. Impaired tissue integrity and risk for infection are common nursing diagnoses for patients with cleft. We all know that the nursing diagnosis is a language that we use. It is a centralized language that allows us to identify our patient's response to organic problems related to their health. Okay, it is in this context that with Dr. Me and Silvestre, we were able to come up with a specialized algorithm for nursing in cleft patients. Okay, algorithms are systems, okay, that allow us to do something in order, okay. And as you can see in this image, this is actually first presented in Mexico in the 4th Lactifa Congress last October. Okay, as you can see, just to give you a brief background, okay, the boxes that you see have different shapes, okay. The, what do you call this? The oblong shape, what they call this, the rectangle, okay, the one with the curved rectangle is a condition, okay. If you see a octagon, that's a decision box, okay, and then rectangles would be action boxes, okay. When we discuss algorithms, usually yeses, that means if our decision is yes, we go to the right, but if the answer to the condition is a no, then we go down. This is a systematic framework used in clinical practice. So you would be seeing this a lot when you practice as clinicians. Even the guidelines, no, systems, okay, hospital systems follow clinical algorithms. Okay, simply put, okay, that's the basic idea. So when we talk of cleft care, okay, we begin from the time the mother is pregnant. As you can see here, ideally, supposedly, at the time of pregnancy, when the mother finds out that she's expecting a baby with cleft lip, cleft palate, or both cleft lip and palate, okay, usually this is done through a scan. We have routine scans done, okay. As soon as the mother is made aware that she has or she will be expecting an infant with cleft, okay, family education on cleft care should be done as seen in action box number 3. With that, we also, as nurses, facilitate genetic counseling because cleft also has a genetic component to it. It is found out that if you have a family history of cleft, there is a chance, there's an increased risk that you might have a child with cleft. But in the normal setting, no, especially for the lower bracket communities where they do not have access to a scan, a congenital scan done, um, what we would do is as soon as they are pregnant, okay, they have to undergo prenatal counseling. No, cleft or no cleft, moms have to undergo prenatal counseling on the EENC, which Dr. Silvestre clearly explained to us a while ago, which is also which is also continued by the discussion of PAM. Okay, so we should be able to do the prenatal counseling, you know. Empowered moms, okay, would be able to know what to do, and we would better support them up until the time they go into labor and delivery, where we facilitate and make sure that the EINC or the 4 core steps is done. Okay, the 4 core step is timed sequence. Okay, it's done. It is the standard of care. I often call it the universal first act of love. So we want every dyad to experience this regardless of cleft or not. So as you can see here, it doesn't necessarily mean that it's just for cleft dyads. So nurses, remember that the prenatal counseling part is to be done to all dyads. Facilitation of EENC is to be done to all dyads, cleft or no cleft. So whether the baby is born with cleft or not, without or with cleft, these steps have to be followed. Now, upon delivery, if we realize, oops, the baby has cleft lip, okay, but was not previously diagnosed. It was not known. They only found out na, baby has cleft at the time of birth. That means we go back to action box number 3 over here. So at the time of birth, after the mom has regained, enough strength, family education on cleft care, genetic counseling should be done. Okay, which is the reason why we see the oblong box over here. Okay. So if, for example, despite the cleft, okay, now that we see the baby is born with cleft or without cleft, we have to consider, is the baby stable or unstable? If the baby is unstable, we are to stabilize the infant. And because the baby is unstable and the unang yakap might not be done, we might not be able to allow them to breastfeed fully at the time, the mother is instructed to express her breast milk. Okay, so Pam discussed a while ago the hand expression. Okay, so that has to be done. Now, if, for example, the baby is stable, or after the baby has been stabilized, we facilitate breastfeeding initiation. So that is the flow of the algorithm. Okay, so here is the actual application of that algorithm. This patient, the mother I came to meet during the time of her OB consult. The OB partner we have in our clinic called me to the room because the mother started to cry after seeing through her scan that her baby is to be born with cleft. So I met up with her. At the time when she had the diagnosis, she was 27 weeks along. So we had the counseling done. Okay, the genetic counseling was done. And at the time of the baby's birth, the baby was 3 kilograms heavy. But because of the prenatal counseling that was done, okay, we were able to discuss things, and the mother came to the experience ready, okay, and prepared. So it was relatively easy for us to facilitate the essential newborn care, and I'm I'm sharing this slide from Dr. Mian, and we talked about the 4 core steps a while ago, so I won't discuss this any further. Okay, so because we were able to discuss it, okay, the mom was able to hand express and collect her colostrum and was given to the baby despite the challenges that they had early on. Now, why do we push for hand expression? Pam mentioned a while ago, we don't want the mom to experience unnecessary oversupply, which will make it even harder for a baby with cleft, let alone a baby without cleft find it difficult to breastfeed if the breast is overly engorged. But evidence shows that early hand expression led to 96% success rates in breastfeeding mothers for more than 2 months compared to moms who pump. No, I always say my position on pumps is that it is a tool, but it is not really an essential. Okay, especially the moms in our country. Okay, especially those who are in the needy, marginalized region of our country cannot even afford to buy formula milk, let alone a pump. Okay, so we really empower them with the basic skills of hand expression. Okay, so after initiating, okay, breastfeeding, making sure that even with cleft, the baby is made to breastfeed, that is when we do the routine care or the eye, what do you call this? The routine care that would include the application of the eye ointment, okay, the injection of the Vita K and the HEPA shot. And this is when we start doing the physical examination after the first breastfeed, considering the baby is already stable. And that is where we should be able to do the palatal examination. Okay, best done after the injection was administered and the baby starts to cry and open the mouth widely for better access of the palate. Okay, I have a picture on the next slide, but let me go through this first so that we can skip it because I understand I don't want to take so much of your time. It's lunch break already. You might start. You might feel hungry already. Okay, so we delay some of we can wait, okay, for this to be done, but we do not interrupt the basic, okay, the essentials, so to speak. Okay, now after the cup, the diet has been stabilized, breastfeeding has been done, and the initial care is done, we will proceed to the infant care and feeding counseling. Okay, so let me go to that slide. So this is the palatal examination. This is an integral part of routine care, and often this is missed out, okay? The correct technique for palatal examination is you would want to torch. Craniofacial surgeons term it torching, no? As nurses, we say we use the pen light, okay, to shine a light on the oral cavity to see if there is in fact a cleft. No, sometimes we also need to use our fingers to feel because there are some clefts that may appear close, but if you feel the palate, it's actually soft because there is the absence of a bone. So needless I say, this important step can be delayed. It's not something that has to be done immediately at the price of disrupting breastfeeding. We don't want to, ano bang term doon? We don't want to disturb the normal process and cause the baby stress, making it impossible for them to latch on and establish the breastfeeding earlier. So this can be done within 24 hours of birth. But I think as nurses, we want to anticipate the care very well, right? And we want to be very systematic when we do things. And so we would want, okay, to time this just as when the baby cries when we administer Vita K or the HEPA vaccine, so we can be able to see it well. Okay, so these are the alternative infant feeding methods, which is part of our counseling sessions for babies with cleft. Right here, we have a nifty cup. This is the one issued by Smile Train. This is similar to the Paladay feeder used in India, which we use for cup feeding. And these are the cups that we see in the clinical area. In some cases, we may use a dropper or a spoon. And this over here, as you can see, the one with the syringe and the tube, is what we call a nursing supplementer. Usually as lactation consultants use this, no, in special cases. Okay. So here is one of my babies. Okay, this is baby C. Okay. You see, after the baby and the parents are guided as to how to use the Nifty cup, they can effectively use it, and this is how the baby feeds. Ayan, ang galing, di ba? Kayang-kaya ng bata mag-feed, no? Despite the cleft. Now, you might wonder, why do we opt for cup feeding and not bottle feeding? Okay, for one, okay, it's relatively hard. The risk for what you call this aspiration is high for babies who let me just ayan. The risk for aspiration is relatively high for babies who bottle feed. Remember, the flow is not controlled by the child in bottle feeding as milk trickles continuously on the baby's throat. No, we often misconstrued as the baby being hungry, but in reality, it's a struggle for babies to latch on, especially if they have cleft, and this increases the risk for them to aspirate. Now, cup feeding is more supportive of breastfeeding in that it allows the baby to pace the feed. As you can see in the video, milk is not we do not trickle the milk into the baby's mouth. We allow the baby to get the milk, okay? The movement of the oral cavity is similar to mastication, which is something normal that we do already. So this is supportive. We also teach this because as the child goes in for surgery, post-operatively, especially after the cleft lip has been repaired, doctors do not want the baby to suckle in a bottle because it will cause dehiscence, okay, wound dehiscence, and it can also cause keloid formation. We don't want that to happen. We don't want to go back to the OR and redo the surgery once again. And so cup feeding is preferred, and even breastfeeding, so that it is more supportive of the repair and the healing of the child's lip. Okay, so as we do this, of course, we want to make sure that the screening test, okay, pre-surgical orthodontics is fitted. Okay, we put the NAM so that the baby would be able to feed. The NAM is a contraption that covers the open palate so that the baby can build or have that suction needed for when they breastfeed. Okay, now in some cases, when this is done, we continue to monitor the development because there's a rule of tens that is followed for cleft babies for them to be able to have the surgery. You see, babies who do not meet the weight requirement, okay, who do not meet the age requirement, babies who do not meet the hemoglobin requirement will not be allowed to undergo the surgery. That's why we have to ensure that the child is fed well and nurtured well through direct breastfeeding and through alternative feeding methods that ensure that they have a good weight gain so that they can be scheduled for surgery the soonest. Okay. So remember this baby of the mommy who I saw at 27 weeks and was given that counseling early on. Okay. This was her after, okay, she was monitored, and now that the baby has the NAM, as you see in the picture in the middle, that's the contraption that seals the open palate so that the baby can form the suction. Now, most of the time, moms would worry, can my baby breastfeed? Ay, di pala nag-work, okay. But in this, supposedly this is a video that would play, but it's not playing. The baby is able to breastfeed with the NAM, okay, with that contraption. So baby can still breastfeed even with the NAM in place. Okay, and because she was guided as to the use of cup feeding, okay, the post-operative care went on seamlessly. As you can see, the child had the lip repair done, and because baby was taught on, and the parent was taught how to cup feed through the nifty cup post-operatively, and even after they were able to maintain their breastfeeding, and the baby feeds, okay, alternatively, and you see the baby growing well without any problems, which is often the problem we encounter for cleft dyads. Okay, let me go back a bit. Okay, now box 19 is something that is connected from the top. I think I could not emphasize this more, that the importance of a parenting support group is involved in the entirety of the process. And I think as nurses, we are in a very good position to allow this to happen because we get in touch with our patients before they get pregnant, when they are pregnant, and after they deliver. Okay, so this is one of the babies we helped who went through the entire, probably one of the inspirations of the algorithm that we have created. So this is Jaron. At the time that I saw this baby, the baby has been hospitalized twice because of aspiration pneumonia. The baby is severely underweight and could not have the surgery done. But through the help of many breastfeeding moms who were more than generous to give their breast milk, and through the support of networks, we were able to rehabilitate baby J, and now we see baby J undergoing the cleft surgery. Now, what are the spotlights to cleft care? What are the things that we have learned from this experience? Cleft care should be client-centered and be comprehensive. It doesn't end when we see them, okay, in the clinic. We have to be able to follow up. We should be able to institute a support group for them that they can run to, okay, outside the four walls of the hospital, the community. Okay, education and counseling early on is important, and nurses play a vital role in this part. Okay, proximity and availability of skilled support is paramount, and this is one of my personal advocacies I share with Dr. Silvestre. We are hoping that the nurses right now listening and the future nurses carry on the torch that we are sharing to you, because there's so much need for skilled help, especially in breastfeeding. We need to strengthen the support base because we are the people in place who can influence that. Research show that nurses are number 2 in the influencers of the mother's decision to breastfeed. Number 1 are the doctors. Okay? Aligned multidisciplinary and collaborative approach is essential. As you can see, I am working with Doc Nian, who is a doctor. I also work with other specialist surgeons. When we presented this, okay, there were surgeons, there were people from other layers of the healthcare system who were there with us. So all throughout this algorithm, it is important that alignment in vision and teamwork at the interface between basic science and clinical medicine builds on the complementary strengths of both institutions, with the critical goal of bringing value to healthcare and our patients. And I am quoting Lawrence Miller on this slide. To end, these are my reflections, no? And I couldn't find the right word, but Rebecca Schnall helped me with that. And it says, I often see myself as the patient's voice. As nurses, we have the advantage of being closely involved in patient's care and can often best understand both the patient's experience and how they interface with the healthcare system. Thank you very much to our listeners. Hopefully, we still have enough time to answer questions that you may have. That is my presentation. There. Yeah. So I think at this point, we are now ready to answer the questions. Both Doc Mian and myself will be able to answer some questions that you might still have. I know you're probably itching to have your lunch, but we are happy to answer some of the questions that you might have. Dr. Orbe?
We would like to ask our students if you have questions. I believe you had questions earlier, but putting it to the end part may have made you forget your question. So you can post it. If you're shy to ask personally, you may post on the chat, or you may ask your questions directly. Dr. Mayan stayed with us, Dr. Silvestre stayed with us, so we can interact with her if you have any questions. And also Dr. March. We have several of our master students here. You can ask your questions now or hold your peace forever, they say.
I think
My
there's one
question,
question from our graduate student who asks, um, can the cleft be treated? I would want to know the context of your question as to can it be treated? Do you mean by that? Do you mean can it be prevented? Is that your question, Fidel? While we're waiting for Fidel to clarify that question, one of our undergraduate students, Prishni, is asking, would like to ask a question. Go ahead, Prishni. You may unmute and ask your question.
Hi, ma'am. Just can you hear me?
Yes, yes, we can hear you.
Just a follow up from my first question is if C if we can if CS delivery if we can apply unang yakap to CS deliveries for the year because we just came from the DR last night, and then what can we do if the administration or the hospital or the doctors don't follow this, because we're just mere students, ma'am, and it's not really our place to tell or remind the doctors that. So what can we do?
Okay, thank you, Prishni. That is a very good question. Doc Mian, how do we communicate? I think that's the challenge Doc Mian and I have been having for all this time, seeing the gap in practice. Doc Mian, what do you think can we do?
Ako,
These
hihingi
are the
sa
future. Doc, ingatan natin mga future to, sila magtutuloy for
Yes,
us.
thank you. Thank you very. Who was that again? Thank you very much.
Prishni.
Krishni, maraming salamat. Sana if you could provide the answers nga to us eh. Okay. As I presented kanina, no, mula 2009 ginagawa na namin to. It's been about 12 years, no. Supposedly yung mga public health programs naman and behavioral change, it takes about 16 years, no. So we're doing pretty good on a public health level, no. Pero kulang pa rin, no. And that's why we as a nonprofit, no, as an NGO, ang approach namin ngayon talaga is training hospital teams actually. So when we do webinars, it's not just pedias, it's not just nurses, it's not just OBs, etc. Is we mobilize talaga hospital teams. So for example, we just held a webinar for Amay Pakpak in Marawi City, no? That was our last face-to-face workshop nitong pandemic, no? So currently we conduct blended workshops now. We design blended courses na may asynchronous learning first on a learning platform. Well, no, our nonprofit does that, no? So asynchronous learning muna at their own convenient time in between duties. They listen to all our lectures, no? And then intermittently during that two to 3 week period, we meet with them and interact with questions. Parang ganito, no? Ang culmination is so asynchronous period of listening to lectures. Tapos may synchronous na meetings, technical sessions via Zoom in between. Tapos culmination is the face-to-face skills workshop, where we actually have performance checklists, no, and we teach them how to do the time-bound sequence, no, or how exactly do you dry? Oy, mali yung drying mo, mali yung hand washing mo, mali yung yung pag-clamp and cut ng cord mo. Oh, but mo inuuna yung no, yung injections, hindi mo pa siya na PPE. Okay, so I'm saying this because the approach is in one single workshop, dapat engaged lahat, no? So Marge also is a PhD in multidisciplinary, actually ako multisectoral learning, 'di ba? And team building, no? So it's an indirect way of saying mahirap, ha? Mahirap, no? And that's why ngayon nursing tayo, mahirap, pero we just keep on working at it, no? Hindi pwedeng pioneer ka lang ng pioneer ng bago. Kailangan you're steadfast at it. Hindi pwedeng ninyas kogon. Kahit 10 years na, tuloy-tuloy pa rin, okay? 12 years na, tuloy-tuloy pa rin. Until every seed is planted, until every obstetrician, until anesthesiologists understand na hindi dapat ma-oversedate yung mother. If that's what we need to do, we will do it. Tama, Marge?
Yes, Doc. Ano yan, ang team song dyan Sharon Cuneta pa rin. Hindi po tayo magbabalot ng lunch. Pero ulit-ulit lang po hanggang ang himig
Ano
mo.
yung Sharon Cuneta nga ulit?
Hanggang ang himig ko yung maging himig mo na rin, Doc. We have to continue. That's why we say, Doc, that's why we say, what is embedded sa old practice, we cannot undo that because minsan yung mga nauna sa atin, medyo resistant na po sila. Yes, Doc.
Ang mantras natin, number 1, evidence to policy, but don't stop at policy. You have to translate policy to practice. And in that translation to practice, there is a lot of unlearning to do first. Yes. Relearning. Learning and even relearning. So what was taught to us and what we taught to the others na ABC, suction, kaagad, kailangan minsan i-undo mo muna. Use educational tools. No? In our workshops, we do a linear sequence of linear sequence. Gloves muna, bago nun, hand washing, gloves, linen, hat, tsaka pa lang ilalagay yung oxytocin and then the umbilical clamp and then the scissors and then ganon. So that linear sequence provides you visual cues so that you're able to unlearn and learn, no? Pero yan yung mga we will not stop until every health facility is aligned, and that's part of our messaging that EENC is standard care. It's not a personal choice of my attending obstetrician or my attending pediatrician. It's standard of quality and safe care for birthing mothers, no? So hindi pwedeng hindi kasi ako breastfeeding advocate so hindi, formula ka, no? That it's and that's why Marge kanina was very careful, no? Sabi niya breastfeeding support, no? Kasi sometimes pag sinabi mong breastfeeding advocate ako, linalagyan ng political color. And there's no political color, no? We're talking science, we're talking medical evidence, we're talking about saving lives. We're not talking about whatever political party or feminist of your spectrum, no? It's just plain and simple. For you as nursing graduates, whether eventually you go into these other paths, no, we're teaching standard of care and we're trying to give practical tips, no? Hindi pwedeng the benefits of breastfeeding, etc. We're also giving you practical tips to be able to help you educate yourselves as future moms and dads, no? Future nanays at tatays, and also to educate your patients. Over.
I think, Doc Mian, as a clinical instructor, my answer to Prishni's concern is this. That is where, as clinical instructor, our challenge at the end. Diba, Dr. Orbe? I think Dr. Orbe will share this with me. Kaya nga meron tayong post-conferences because the reality is when you go on clinical duty, you will not only see what is ideal, but you will see the horrors as well. And that is why we teach you what should be done so that you, in hindsight, can say, if I were the clinician, I can improve on this aspect because the book teaches otherwise, the practice, there's a disconnect, but I see the value of what the evidence tells us. And so as clinicians, you later on correct the wrongs that you see. Dr. Orbe, you were raising your hand. Please join us.
Yeah, I really appreciate the fire that Dr. Silvestre is trying to show, no, kasi teaching doesn't come right away. I mean, the learning doesn't come right away. Some learning curves go the long way, especially that some of our clinicians and our practitioners in the area, nurses, as we may um, relate to them, don't go the higher level of education, and they're contented with what they learned years before. So wala pong upgrade. Pagdating ng mga students sa area, yung old practices pa ang nakikita nila. And I believe that most of our students here, being on level 2, are maternal and child students, and they really are up to see what is in the delivery room area. And the first catch of the baby. Kaya nandito po sila kasi I believe they have notes na, wow, dapat ganito pala. Wow. The
Yes.
ideal they see now.
Yes.
So, yeah, parang Doc, I like the point na I think that's why Prisney asked the question, because she might have observed things already in practice, and we'd like to support the point na we'd like to educate and re-educate, learn, unlearn, and relearn. Parang ganun ba?
Yes,
Na
yes.
how can we help, especially Doc, sa mga lying-ins?
Yes, yes, yes.
There's a big gap for that. Yes, Doc.
Kasi when we were doing our formative research, ibig sabihin yung baseline, no? Baseline situation analysis, no? Ang nakita kasi namin sa educational models din kasi, and I'm not pointing fingers pero kunyari, with a clinical instructor, you go into the delivery room, correct? May CI, tapos may 5-6 na estudyante, na nursing students. And what I observed was that each of those 5 or 6 nursing students has a particular task to do. O ikaw, maglagay ka ng name tag. Ikaw, mag-footprinting ka. Ikaw, mag-suction. Ikaw, mag-ganon-ganon. And nawala tuloy yung time-bound sequence, no? So, dun sa aming formative research, imagine yung footprinting, 8 minutes pa lang yung bathing, halos 8 minutes pa lang yung bata nagawa na kasi yun ang assignment niya in the team. In the team that is supervised. No? So, kumbaga, may elephant and then nakikita mo lang yung trabaho mo, no? So what we're trying to undo is that things have to be a seamless na time bound. Hindi yung kanya-kanya ng trabaho. It's not a do what's assigned to you, but respect the needs of the baby, respect the needs of that mother and the dyad in that narrow space, in that narrow window of time and space. Now, in the grand scheme of things, kahit mag-isa ka, actually kaya mo yan. You can do things even if you're alone. And that's what we try to demonstrate in our hands-on skills workshops is even if you're alone, and Marge was able to participate in our workshop in Silang, is that even if you're alone, you still do that sequence. Even if you're in a team, you still follow that sequence and not what's been assigned to you. Okay, so because what's assigned to you has been you have to do 10 cord dressings, wala nang ganon, no? Kasi dry care na ngayon. Dati nung interns kami, we're supposed to trim the cord and put the OS and put the betadine, ganyan. It was driving the behavior. For example, OB residents, they have an academic requirement na dapat maka 10 episiotomy, 20 episiotomies. And this is driving behavior when not all women need episiotomies, no? Not all women need to have a routine IV fluid. Not all women have to have a urinary catheter, no? So these are all the practices that should not be driven unnecessarily by academic requirements. Okay, so as university-based pre-service professors, basically, we should really review the nursing curriculum so that these academic requirements are not driving unnecessary behaviors.
Thank you, Doc Mia, for that. Thank you for considering the
Yeah.
valuable role of the
My mom's a nurse, disclaimer. My late mother was a nurse.
Yes.
Yes. Yes. So mahal na mahal.
Ayan, oh, mga nurses. Thank you, Doc. Let's go to the one of the questions from our graduate students, and maybe Doc Mian can help me answer this question. It's about cleft. No, we understand that one of the things we talked about previously, in in the many engagements we've had together, is the importance of emphasizing nutrition prenatally, because it has an influence as to the development of the child. Because one of the questions here is, what increases the risk of cleft
Okay.
babies?
Okay.
Doc?
So I can parang tempted na akong i-share na tuloy yung screen ko ulit, no? Pero basically kasi it's two things, ano. You can have either a genetic predisposition, okay? So pwedeng familial, okay? Here we go. Can you see this?
Yes, Doc.
Okay. So you can have either a genetic predisposition, ibig sabihin sa family o pangatlo, pang-apat na cleft na pala, no? Or in a cousin or in a first degree relative, no? You can have a genetic predisposition, but you require an environmental factor to manifest. Okay, may predisposition pero may environmental factor. And one of the environmental factors that can be modified, modulated, is the environmental factor of nutrition. Okay, and that's why yung sinabi ni Marge kanina na genetic counseling, that includes identifying which is parang a familial tendency, or if it's syndromic, no? There are some syndromes which are fixed genetic sequences na nagkakaroon talaga ng mga clefts. For example, you might hear Pierre-Robin, no? Or you might hear the Mobius syndrome, no? So may syndromic, yung syndromic hindi madaling i-modify yon, yung syndromic, kasi nasa chromosomes, no? And sometimes they occur accidentally, like a mutation or sporadically. It's the ones that have a genetic predisposition that become manifest only when exposed to an environment, no? So yan yung tinatawag na epigenetics, no? Yan ang dapat talaga, if you have a previous baby with a cleft at i-report mo yun sa genetic counselor, then you can start periconceptional folic acid supplementation, okay? Ibig sabihin, the mothers don't even know they're pregnant yet, then they should be put on folic acid, that because the folic acid in vegetables and breads may not necessarily be enough to prevent the mutation from happening, okay? But they can be corrected surgically so that halos close to normal. But the most important thing is that timely ang intervention, especially for palates, because kapag nasanay yung baby na the hard palate or the soft palate is abnormal and there's a gap, when they start their speech, they compensate by using different muscles in their throat and nasopharynx, no? And therefore, if you're able to correct the cleft palate, but it's so late, the residual hypernasality, no, yung Tagalog ngongo, still remains. Okay, so that's why we're working very, very hard to improve the nutrition through breastfeeding of cleft patients para hindi na delay yung surgical repair.
And I think, Doc, that presents that supports the first 1,000 days, which is
Yes.
Where breastfeeding is part, really, because we can change the trajectory of the health of the babies and the
Yes.
mothers as well.
During
Now,
pregnancy and at
yes.
birth. Yeah.
Yes.
So
Continue on with what you said, di ba, yung sa Sir Repairs, Doc. There was a question as to when should the repair be done. The repair can be done as early as 3 months. Provided, di ba, Doc? Provided that the baby fits the bill, meaning na-satisfy yung rule of tens. Okay, yung the age, the weight of the baby is appropriate to age, or at least the baby's weight should be around 10 pounds. Okay, the hemoglobin level should be 10 and above, okay, and then the age, yun nga, is 10.
That's for cleft lip.
Yes, cleft lip. But for the palate, I think it's much later. It is done much later. So the repair for the lip is done earlier, okay? And then when the child hits that certain weight, and the health, of course, because they cannot do surgery for a sickly baby. Okay. I think they want to do the palate repair, they want to do it as soon as possible, because it has been said that if the repair is done early, the less the dangongo is seen. Okay. That is basically the idea. I think that answers the question, okay, that we have here. Ano pa ba? Is there full Ma'am Claire Mogol, one of our mothers, okay, a breastfeeding supporter, asks, is there an EINC subject, full subject? EINC as a concept is part of the MCN subject, Ma'am Claire. But it is not as extensive because, when you want to go into this in detail, or you want to go into lactation in detail, that is a specialized field of nursing. So it is not really part of the main course or the curriculum. But we're working on having the students have more clinical experience in the conduct of their clinical duty to handle breastfeeding dyads. Supposedly that is the ideal, but we're still working on that, Mommy Claire. Doc.
Wow.
Yes, Doc.
Marge, just quickly kasi alam ko gutom na tayo.
Yes, Doc.
I shared kasi kanina si Ma'am Pam Stout
Yes.
shared a form that they use, and then they said, I hope that your patients are going home with this form, ano. So I put it in the chat box. Can you see it? Okay. And this is the form that we give out. No, this was formulated by a member of a mother support group called Latch. No? And can you see my screen?
Wala pa, Doc. Pa-share screen po.
Yan. Can you see it
Yes,
now?
it's
Yeah,
it now.
okay. So ang unang linggo ng pagpapasuso, so all in Tagalog, no? You can hand this out to your moms, no? Kesa yung parang puro note writing, kept warm and dry, kept warm and dry, wala ka ng katapusan, kept warm and dry, annotate sa medical record, no? You just ask the mother, no? In the first day of life, you only require 1 pupo, 1 wee-wee, and maybe 4, maybe 6 breastfeeding episodes kasi tulog sila, no? And then on the right column, you have the danger signs, okay? On day 2, dumadami na yung breastfeeding, pero you'll see that there are icons for breastfeeding that are lighter or grayish, no? So the really black icons, yung parang medyo minimum sana, okay? And then the gray ones are yung additional, okay? So they will not stool or wee-wee 6 to 8 times a day in the first 1 to 2 days, okay? Kasi that is forcing the 6 to 8 times a day, makikita nyo dito is the day 4 or day 5 pa, okay? So if you have this copy, and then you can familiarize yourselves also, you don't use the weight, no, and weight loss, especially if you're using different calibrated scales, no? One in the DR and one in the wards, magkaiba naman. And then kapag more than 7 to 10% weight loss, hala, formula ka na. No, you go by elimination patterns. And message to nurses and message to doctors also, we have to be familiar with what's normal for babies, no? Puro tayo what's abnormal kasi. Dahil ang nagtuturo sa inyo mga espesyalista sobra, tulad namin, okay? Okay, so what I'm trying to demystify is things that we should know, normal behavior. Hindi lahat ng suka ay dahil may sepsis yung bata. Baka na-overfeed mo with the bottle. Baka na-prop mo kasi ang daming pasyente sa NICU. Okay, etc. Okay? Over.
Thank you, Doc. Dami, no? Marami kaming hugot ni Doc Mian kasi kami yung nasa troubleshooting end. That's why we are grateful that we were invited to share some of our insights to you. I think there's one question, Doc. I'm the best person to answer this. It was sent to me on Messenger. What about daw po breastfeeding for babies with galactosemia, Doc?
Galactosemia is the only contraindication to breastfeeding. Pero what is understated is that commercial formula is also contraindicated in galactosemia. Nagigets nyo ba yun? Okay. It is the only absolute contraindication to breastfeeding. Okay. But it also absolutely contraindicates commercial formula feeding because of the lactose in both breast milk and formula feeds. Malinaw po ba yun? Okay, so HIV is not an absolute contraindication. In fact, the current recommendations is you still exclusively breastfeed. Hepatitis B, lalong hindi dapat formula feeding. Clefts, hindi rin. Prematures, hindi rin. Ano pa? G6PD, hindi rin. Okay. So and nurses should not be bottle feeding formula just so that their newborn screening can be performed. Okay, so please, standard messages lang tayo. Wag marketing messages ng mga milk company. Okay, that's why we steer clear of all other influences. Sana dahil just like a fire code and a building code, these are laws that are intended to protect us and our families. Okay po?
Wonderful. Doc Mian, in closing, ano po ang pabaon natin? What would be your pearls of wisdom for our attendees this afternoon? Afternoon na pala. Sige po.
Ako, ang haba na, no?
Okay lang, online naman po. Kumakain na yung mga
ma-synthesize. Okay. So let's start out siguro with the framework of the first 1,000 days, no? Everything we do, whether ikay pediatrician, whether ikay obstetrician, nurse, whether ikay mother or father, and especially because you soon hopefully will become mothers or fathers, no? Should be anchored on the mother and the baby dyad sana, no? Don't look at them specialty wise as hindi OB nurse ako, hindi pedia nurse ako, no? And that framing on the mother-infant dyad will also guide you in all that you do, especially for one of the most potent of life-saving interventions, and that is infant and young child feeding. Okay, so start with prenatally or antenatally educating your parents with standard messaging, not what you hear on TV. Okay, na for the mother who cannot breastfeed, no, or ano pa yung kanta? Micronutrient deficiency, kakapika. Okay. Okay. So standard messaging, by standard, that is from the Department of Health, from the World Health Organization and UNICEF. No, start out with preparing the moms antenatally, preparing them for an unang yakap delivery because breastfeeding should be started in the first hour after birth, except for cases where you cannot, and those cases are kapag newborn or mother ay in distress, no? Okay, and then continue with exclusive breastfeeding up to 6 months. Don't introduce at 4 months. The evidence does not show that it is favorable to introduce at 4 months despite the commercial messaging, okay? And continue breastfeeding up to 2 years or beyond. Kahit 4 or 5, basta may usapan pa rin kayo tulad ni Marge tsaka ni anong baby? Huh? Okay. Continue breastfeeding up to 2 years or beyond into the extended breastfeeding years, while starting up with locally available non-commercial mashed fruits and vegetables and animal sources of protein. Tama sapat ang exclusive breastfeeding. Don't give in because of initial difficulties, no, at birth, especially in the first weeks of life, and seek support and provide support. Get trained for it so that you can be that warm circle of support for our mothers and babies. Over.
Thank you so much, Dr. Silvestre. Indeed, it is said that it is cruel to promote breastfeeding and fail at supporting it. And I feel as nurses, we are in the best position because in reality, we spend a lot of the time at the patient's bedside. And sometimes, it is our messaging. Yung mga well-meaning but not thought of messages na, ay, wala ka pang gatas. Ay, kasi ganito yung suso mo, mami, na sinasabi ng mga nurses that causes the derailment of a mom. So I hope that's my message to the nurses here. We have a very important role in the support of the dyad. In fact, I call it triad pa nga kasi kasama si daddy.
Si Daddy.
Diba? So it's really important that we know our role and we take that to heart because the lives of many beyond our years depend on the influence we give to them. With that, thank you so much, Dr. Sylvester, Dr. Joyce T. Orbe. We are now ready for your closing thoughts and the prayer.
Mary, can we do the vote of thanks now?
Yes, Doc. Thank you, everyone, for making this event possible,
Thank you po,
especially to
ma'am.
our guest speakers and to the undergraduates who attended. And yes, and to Dean Hail, who participates, who gives the welcome speech, and Dr. Orbe. Thank you so much.
At this end, we would like to, I know the certificate is not enough to really say our thanks. No, we're beyond words, Dr. Mian, for the time you really created so that you can be with us this morning. Your holiday was half spent with us. And I guess that is one thing that we will treasure, and the knowledge that you also shared, so that in our practice, we will be able to help support and enhance the practice according to what is evidence-based. So as I read the certificate, we would like to give the certificate of appreciation to Dr. Mian Silvestre, neonatologist, neonatologist and MCN consultant, in grateful acknowledgement and sincere appreciation for having served as resource speaker in the Nursing Graduate Studies webinar of the course Growing Family, with the theme The Persons and the Practice, Maternal and Child Nursing Perspectives in the Now, the New, and the Next Normal. Given this 8th day of December 2022, Adventist University of the Philippines, Puting Kahoy, Silang, Cavite. Signed by our project coordinator, the leader of the group of our graduate students who are sponsoring this webinar, the professor, yours truly, and of course, the Dean of the College of Nursing, Dr. Susie A. Hael. Thank you so much, Dr. Silvestre. And with that also, the certificate of appreciation for Dr. Maria Julieta S.J. Sibayan, of the same words and thoughts that we wish to encapsulate our thanks to you in grateful acknowledgement and sincere appreciation for having served as one of our resource speaker in this Nursing Graduate Studies webinar in the course Growing Family, with the theme The Persons and the Practice, Maternal and Child Nursing Perspectives in the Now, the New, and the Next Normal. Given this 8th day of December 2022, Adventist University of the Philippines, Puting Kahoy, Silang, Cavite. Signed by our project coordinator, the professor of the course, and the dean of nursing. Thank you so much. Of course, our participants will also receive their certificate of participation. However, right in the chat box, you will see a link that would help us evaluate the program so we can improve more, especially on our graduate students webinar exposure. So we want you to get into that link and then do your evaluation, and automatically after your evaluation, you get your certificate with it. So we thank you so much, the rest of our participants. Okay, so there's the link. You can you can try to check the link so you could get through the evaluation and get your certificate of attendance. While you're doing that, I would like to say my personal thanks. I know Palm Stout is already out because of time, but I'd like to say thank you talaga kay Dr. Mayan. Nasanay na rin ako mag-Mayan kasi si Dr. Marge, that's how she introduced us to you also. And she really had very good recommendations on how you will teach us as a speaker and how we would learn from the time you will spend with us. I know there are more we wish to learn, and there's more in your expertise that you wish to share too. But what you shared today was so much so that it made us think a lot what our roles would be when we see ourselves in practice. And you were saying about considering how assignments of students would do in their exposure in the delivery room. And we're trying to think about that, and also the protocols of the hospitals where we affiliate. Sometimes we wanted to, but the hospitals also have their own protocols. But we wish, as you said, there's not stopping to the policies, but there's more to the training, and there's more to the learning, relearning, and also taking out some things that we don't need to really embrace now, and coming in or embracing things that we need to learn because evidence are beyond our reasons of just staying where we are, because we need to grow and we need to also improve in our practice. Thank you so much, Dr. Um, Silvestre. I know this may not be the last. We may recommend also circles in our master's program where we can invite you again, because you are saying it at a level wherein we could help as we see the policy coming out and in application already in various sectors. We on our level as nurses and educators as well would be able to help in putting the policy right in place and being aligned with it as well. And thank you for helping our students open their eyes to to the next practice, but it's also a now practice and maybe new to others, but we need to adapt because it's now supported by a lot of evidences that is for the safety and for the good benefits of our diet as well. So God bless you, Ma'am Sibayan. Thank you so much for helping us out with your shared clef care also. And our roles there would also surely be improved. To our master students, thank you so much for, I know you had jitters when you have to go through this webinar, but now that you learned how and you see how we check into the expertise of our speakers, you will open your eyes that more webinars would be coming up with you heading and hosting, because we need to pass on the good practices that we need to improve as we learn new things and adopt evidence-based practices that has been relayed to us. So we would also like, on the end part as I close, I'd like to thank the super support of our Dean of the College of Nursing. I know she's been busy, but her holiday was also, a part of her holiday today. Like Dr. Mayan was also given space for this webinar to also be a part of her day. Thank you so much and God bless you. Don't forget to do your evaluation. We will stay a little longer after my prayer so we can have picture taking, because we want to take documentation with Dr. Silvestre and Dr. Sibayan as well. So before we have our picture taking, I'll invite everyone to close this with a prayer. Ma'am Susie, are you saying something po but before we pray? Okay, so I think that means we have to close with a prayer, and then we will have a picture taking, and then we can go. So shall we bow our heads for prayer? Our dear Father in heaven, thank you so much for guiding and blessing us today. Thank you for very good speakers who have the heart to volunteer and to share their practice, which has opened our eyes to a lot of things that we need to support and also do, so that we will be able to align ourselves, that our dyads will be well protected, they will receive the quality care that's needed, and we will be able to let them live a life that is the best, and that is what you decide for them to live. We thank you, dear Lord, for our students, both the graduate and the undergrad, and we thank you for teachers who have supported, for those who are also enthusiasts in breastfeeding and the care of our dyads. Thank you for having them with us today. May we all praise your name, and may you continue to guide us, support, and provide for all our needs, so that we will thank you for your goodness and for your love. And may we spend our holidays happy, healthy, and being true to you and faithful to you too. This we pray in the loving name of Jesus. Amen.
Amen.
Okay, so let's have, sige, Ma'am Marge, take it away.
Ano ba? Picture taking ulit. For the
Picture taking.
persons.
Yeah, we
Ayan.
need to have a remembrance with Dr. Mian and you.
Sige.
All right. Paano ba yon?
Can we ask ano na yung share screen? Teka, wait lang.
Unshare mo na.
Share
Yes.
na, yan. Picture lang. Ito yung mga survivors. to the very end.
Please turn on your camera so we can have this moment with you.
Ano ba to? Mas may plus points to kay Ma'am Sibayan dahil nagstay hanggang end.
I wanted to tease you a little. Hindi ko nasabi sa aking closing remarks ha. Yung nursing, yung term na nursing, saan kaya siya nanggaling, di ba?
Kapasuso. Yes.
Breastfeeding na breastfeeding.
Yes, kaya dapat magagaling mag-breastfeed. So, take na ako ng photo.
Yeah.
Yan.
You may put a heart on your photo.
O, sige, heart daw. Heart,
our
dali. Pagkakuhanan ko.
Everyone.
Yan, heart, ready? There. Okay, tapos next page. Heart din.
Heart, everyone.
There you go. Got it. So again, thank you so much for Doc Mian. Maraming salamat. Marami po kami tutunan. Sobra, as always. Baka El.
Thank you so much, Dr. Silvestre.
No
Mama,
worries.
thank you.
Well
Grabe. Yung time ni Dr. Silvestre, halos 4 hours yun, Mama, ha?
Yes.
4 hours.
No problem. Glad to be of help, and I always learn also kasi.
Ayan. Parang naisip ko nga.
Salamat. Alis na ako.
Thank you, Doc.
Bye-bye.
Happy lunch na po.
Thank you, everyone.
Thank you.
Make sure ko nga na yung ginawa
Thank
namin.
you, Doc. God bless you.
Thank you. Yung sa unang yaka, pwede gawin na component ng skills lab nyo sa OB. Kasi nag-a-assist naman tayo ng delivery. So you can actually incorporate.
Ma'am Joy, exit muna ako ha.
Yes, ma'am. Yes,
Thank you po.
For the students, please just do your evaluation, see the QR code, get there, do the eval, and then right after, you will see your certificate also for you to claim. For our grad students, you may stay for a short while. Just a short afterthought. After reflections. Ano, Ma'am Marge?
Yes po, ganun. That's
how we Nako, June. Sir June, ako na tuloy naka-pray. Dapat closing prayer si June eh.
And thank you to the undergrads. Congratulations to our graduate students.
Yes, thank you. This is your part 1. The part 2, will be doing everything now. Marge will just observe.
Oo, kakain lang ako bang
May part 2 kami eh. Yeah, after doing your evaluation, you may exit. Except that the graduate students can stay. Marge, short time lang ha. Kausapin ko lang tong mga grad student.
Yes, so may tanong, do we follow the EINC here or the one taught to us? Sequence po ng unang yakap. The sequence of unang yakap remains the same.
In the clinical area, we follow the unang yakap kasi EINC.
Yes,
However, there are times na pag na-handle ng nurse at sinaway kasi yung protocol nila.
hospital.
We will see that the hospital will also get into that once the policy becomes national by implementation. But the policy is already in place. So little by little, education needs to be spread out to all hospitals, whether private or non.
Pero ma'am, pag exam, you follow the ideal sa exam.
Mm-mm.
Yeah.
Nandun
Ayan.
naman, EINC talaga ang fina-follow nila.
Ayan. So thank you to our undergrads. Pwede na po
Thank
kayo
you,
mag-exit.
undergrads. Thank you, MSN Level 2. Your support has been very, very appreciated. Yan. Sige, hintayin lang natin mag-exit sila ng konti. Pero grad school, kain na kayo habang magmi-meeting lang tayo ng short time. Konti na lang sila eh. There's your, yeah, I think there's 18 more minus the graduate students. That would be 5, 6 of us.
Ilan ba yung graduate students natin na matitira?
Lima lang yan. 1, 2, 3,